Welcome everyone to the final day of INASL 2021. So starting with the first session today, I will like to invite our chairpersons, Dr. Sudhanshu Kesi from Nepal, Dr. Ajay Jain from Indore, Dr. Pradeep Bhaumik from Tirupura, and Dr. Sanjeev Nishavan from Jaipur. I invite now chairpersons to preside over the session and call the first speaker first for the first presentation. Sir, you are mute. Dr. Sudhanshu, please.
Oh, I'm sorry. Good evening, everyone. It's my pleasure to chair this session. I would like to thank Dr. Kausal Madan and INASL for giving me this opportunity. I'll be chairing this session along with Dr. Pradeep Bhaumik, Dr. Sandeep Nijawan, and Dr. Ajay Kumar Jain. So today we are going to have 4 talks by eminent speaker. The first speaker will be Dr. Abhay Phillips. He is a senior consultant, clinical and translational hepatology, and affiliated with Delivery Institute, Center of Excellence in GI Science, Rajgiri Hospital, Kochi, Kerala. It's my pleasure to invite Dr. Abhay Phillips, please. Dr. Abhay Phillips?
Yes, I hope I'm audible and my slides are visible.
Yeah.
Thank you for inviting me for this talk. Thank you to INASL and specifically the scientific committee. And thank you for the kind introduction. My session for today is on fecal microbiota transplantation for liver diseases. Is it ready for prime time? So I'll briefly go into why this is important and what current evidence for us to use FMT is in liver diseases. So as we all know, there is there's something known as gut barrier health. It actually is a very complex phenomenon where we have a lot of gut microbiomes that actually defend or help us to promote homeostasis within us. For example, immune system, the immunity in our body, inflammatory processes, and also metabolic functions at various levels are all defined by this particular group of organisms within our gut, and this is maintained by the gut barrier health. Now, what happens in health is that it is not just the bacteria or the type or the quantity of bacteria or the virus or the fungus that we see in our system that actually promotes what is known as gut barrier health, but most importantly, it is their function. This is something known as metabolic function. So not just the type and amount of bacteria or the other organisms, but the functions are most important for us to promote or maintain homeostasis at the gut level, which actually affects local and even systemic levels. Now, we all know there is something known as dysbiosis. So dysbiosis is when there is a change in the quality and quantity of microbes. And this has been very well shown to be associated with multiple liver diseases in animal and also human models. So actually you can see in this particular slide, mouse models and even in fish models and also in primates and humans, specific group of bacteria has been associated with specific liver diseases. Now, let us take an example of cirrhosis. I mean, the commonest liver disease that we see is cirrhosis. In cirrhosis, if you can note, various preclinical studies and also clinical studies have shown that specific groups of bacteria can actually affect the human body and the liver environment with respect to inflammatory processes, immune functions, and also this can actually lead to changes at various organ levels, organ systems, whereby we can actually have promotion of sepsis, organ failures, specific clinical events in liver disease such as encephalopathy, renal injury, and also acute and chronic liver failure. Now, this is all dependent on loss of barrier function. And this barrier function actually happens because of multiple etiologies and also progression of liver diseases. So the dysbiosis actually can promote or initiate a liver disease. It can actually promote progression of a liver disease and actually also affect different clinical events in particular liver diseases, for example, sepsis, encephalopathy, or extrahepatic organ failures. Now, not just the bacterial population, but the functions. For example, if you look at this particular slide, you can see that various bacterial metabolites like choline and methylamines, and also endogenous bacterial metabolites like ethanol and other inflammatory cytokines actually lead to local and systemic inflammation. And this is all associated with changes in bacterial population and bacterial communities within the human body in various liver disorders. So this metabolic function is what actually drives systemic inflammation and immune functions that later lead to various organ system involvement and also progression of liver disease. And this has been very well shown in a host of liver diseases. Now, these are the liver diseases where we actually have good data that shows that dysbiosis actually promotes initiation of liver disease, promotes progression of liver disease, and is also associated with specific clinical events in liver disease. For example, if you look at hepatocellular carcinoma, Escherichia coli has been shown to be increased at the gut level in patients with hepatocellular carcinoma with underlying dysbiosis. Similarly, in alcoholic liver disease, the change in bacterial population has been shown to promote intestinal permeability, endotoxemia, and systemic inflammation, which drives various clinical events in severe alcoholic liver disease. Now, what is new? So this is from our latest paper, which is actually in press in Indian Journal of Gastroenterology, where we actually show that it is not just progression or initiation of liver disease, but very specific clinical events can be associated with dysbiosis or a change in bacterial function and population. For example, if you look at this group of bacteria known as Halobacteriaceae or Turribacteriaceae, this group is associated with high MELD in cirrhosis, in severe alcoholic liver disease, and bacteria such as Eubacterium and Capnophytophaga, they are associated with high CTP scores. Similarly, there are specific groups that are associated with kidney injury and specific groups that actually promote a severity of alcoholic hepatitis or sepsis. And this actually is very important because we understand that there are a group of bacteria that can actually initiate specific events in patients with severe alcoholic liver disease. Now, in another paper, which we recently published as an abstract form in Gut, and this paper is under peer review, we showed that not just hepatic and extrahepatic events, but infections per se. A lot of infections that we see in cirrhotic patients are actually because of dysbiosis. Now, dysbiotic bacteria actually has been shown to promote repeated infections, and in those patients with repeated infections, a change in bacterial population has been shown to be associated with immune exhaustion. That is why we have a lot of multi-drug resistant infections in cirrhosis. And this is beautifully shown by us in this paper, where we show that beneficial groups are associated with lesser amount of sepsis, lesser episodes of sepsis, and pathogenic or pathobions. The use of antibiotics and hospitalization was associated with more episodes of sepsis and organ failures in cirrhosis. Now, coming to FMT per se, it is not a new thing. It has been going on since 4th BC in China. And Li Shenzhen is the first person to use freshly prepared stool samples to treat diarrhea in children. The modern FMT practice was actually started by Ben Eisman, a surgeon for pseudomembranous colitis. And we very well know that recurrent C. difficile infection, FMT, is one of the approved protocols. This has also been used by veterinarians, where they use healthy cattle stomach contents and transfer it to sick cattle to prevent or treat diarrheal diseases. And this has been in use for decades. So FMT per se, this is how we screen the patients for the donors for the patients. And this is part of collection. This is how the procedure is done. So I'll just briefly go through this. The screening is mostly like how we screen for blood in blood banks. And in the current situation, we have to screen for COVID also. We can collect the stool sample and use it within 6 hours freshly, or store it at -80 degrees and use it for a couple of years after thawing. We actually can blend or manually strain the stool samples, and we can either give it through upper GI or lower GI route. And depending on the route, the doses can be identified. For example, it is 100 ml into the stomach and 200 ml into the duodenum. And in the lower GI route, we can give up to 500 ml. So this is how we do FMT through endoscopic procedures. And this is how it is done through the nasoduodenal route in a patient of severe alcoholic hepatitis. What evidence do we have regarding this? So we have data on alcoholic hepatitis. So this is our paper where we showed that FMT actually improves survival in severe alcoholic hepatitis patients, and also in patients with acute and chronic liver failure who have severe alcoholic hepatitis, where the survival was up to 60% plus at 1.5 years. Again, FMT was shown to be better than other standards of care like steroids and N-acetylcysteine in a group of patients where we analyzed retrospectively. Prospective trials are awaited. Also, this is a recent paper which we will be presenting at IDDF in September, where we showed that FMT, when done in severe alcoholic hepatitis, the benefits last up to 3 years, along with similar changes in microbiota, and compared to standard of care, where there is no change in microbiota, the survival was lesser. There was a Bajaj group from USA showed that FMT was useful in recurrent itch in the short term and also in the long term, compared to standard of care like lactulose and rifaximin. And also his group showed that performing fecal microbiota transplantation in cirrhotic patients reduced the multi-drug resistant gene expression and reduced multi-drug resistant infections in advanced cirrhosis. Also, FMT in primary sclerosing cholangitis was shown by our group and also by Jessica Allegretti's group in the US, where we showed that the liver functions improved with FMT, and this was associated with improvement in survival and improvement in recurrent cholangitis episode, as shown by our study, which was published in 2019. So currently, where are we at? So we have evidence to show that dysbiosis initiates or worsens liver disease. It predisposes liver disease patients to infections, promotes recurrence of infections, is associated with extrahepatic organ involvement, and with multiple liver events such as sepsis, liver failure, and hepatic encephalopathy. And we have some preliminary data from multiple centers which show that there is improved survival in severe alcoholic liver disease when with the use of FMT. FMT also improves hepatic encephalopathy, and there could be a benefit in the reduction of multi-drug resistant infections. So is it ready for prime time? So we have actually, I mean, when we look at FMT data currently in our practice, we actually see that we have more questions than answers. Even though we have shown that fecal microbiota transplantation reduces mortality in severe alcoholic hepatitis or can reduce infectious episodes and can reduce hepatic encephalopathy, we are still not sure about the timing. And what are we going to treat? Are we going to treat a clinical event associated with the liver disease or the liver disease per se? We have to identify the ideal dose and route. What is a healthy microbiota? Who is an ideal donor? We know there are terms like super donors, but we have not actually defined it well. So we need to identify healthy microbiota. We need to identify groups of microbiota or bacterial population which are beneficial for a specific clinical event or specific liver disease etiology. We still don't know about this. And also updates regarding screening protocols, because now in the pandemic era, COVID-19 is also an important aspect which has been entered into the protocol. So these protocols will keep on changing in the future. And we also don't know about carcinogenicity with FMT, because we are transferring a lot of microbial DNA and a lot of metabolites, and that can actually affect us in the future. We are then unsure about carcinogenicity. And what are we targeting? Are we targeting only liver failure and events, or what about liver fibrosis and portal hypertensive events? We don't know about these events currently. And should we just perform FMT once, or can we repeat this? And how would it benefit the patient while repeating FMT, and what are we looking at? I mean, these are all the questions that we are yet to answer. And also about long-term effects. Beyond a decade, at 10 years, at 15 years, what happens to the patient after he gets FMT? Because we have seen that patients developing obesity and diabetes after fecal microbiota transplantation, and these metabolic diseases can be transferred through stool transplantation. We need to have a very clear-cut view of how this is going to affect the patient in the future. So the simple answer for the session at the moment is not yet, because we have to have a proper clinical-based research protocols, and I think more institutions should take up the FMT protocol so that we get better and better ideas regarding patients and their clinical events and effect of and benefit of FMT in such a specific group of patients. I thank you for your patient listening. Have a good evening.
Hello.
Sir, please unmute yourself. Dr. Sudhanshu, please.
Well, thank you, Dr. Philip, for a nice presentation. And now we know the power of book, and you showed that it is beneficial in so many clinical conditions. But the question is when we can transfer these techniques to every hospital. With this, I invite questions from the panelists or other members who are listening to this important topic.
Dr. Abhi?
Yes.
Yeah. Is it easy to do the tests? Is it easy to do the test on the stool to see that which predominant organisms are there?
So this particular test that we do is something known as 16S RNA metagenomics, and currently there are newer methods known as shotgun sequencing. These are actually easy to do because most of them are software-based programs that we have to run. But the issue is that they are expensive, and we'll not be able to do this on a routine basis because they are still under research protocols, and funding is an issue for us to run these clinical protocols, because it's an expensive process to actually identify the gut microbiota using these techniques. So routinely, it is not so easy.
And the other question was like the type of procedures you showed for treating such patients, giving into the stomach or duodenum or in the colon. So it looks cumbersome. So do you suspect any future of giving it orally in the form of capsules, so that it becomes easier in clinical practice?
Yes, of course. The use of fecal capsules, they call it capsules, have been actually identified, and it's actually been used in the US. This company known as Open Biome is actually making fecal capsules, and Professor Jasmohan Bajaj's group has actually used fecal capsules and showed that it is as effective as other modes or other routes of FMP. And yes, the problem is to make these fecal capsules available commercially because they're very expensive to make. But in the future, yes, I definitely believe oral form of FMP will be available.
Dr. Philip, have you used this technique in treating NASH-related cirrhosis?
So this particular protocol of FMT is currently under. There are multiple clinical trials recruiting at the moment for NASH, FMT for NASH. But we don't have any preliminary data to actually show. But I think in the next 3 or 5 years, we should have some data on utility of microbiota modulation in NASH patients using healthy FMP.
Okay, if there are no more questions, I thank you, Dr. Abhi Phillips, for a very informative and innovative presentation. And our next speaker in the line for this important symposium on clinical practice of hepatology today and tomorrow is Dr. Narendra Singh Chaudhary, who is a senior consultant at Medanta, the Medicity Hospital, Gurugram, Haryana. And it's my privilege to invite Dr. Narendra Singh Chaudhary for his presentation, which is for about 13 minutes, followed by a discussion of about 2 minutes. Dr. Narendra Chaudhary, please.
Thank you, sir. Am I audible, sir? My slides?
Yes, yes, your slides are visible. You are audible. Please go ahead.
Thank you. So I will discuss managing liver dysfunction in initial 6 months. So when we discuss graft dysfunction in initial period in 6 months, early allograft dysfunction or small pore size syndrome, primary non-function and IR injury, they remain a differential diagnosis in early period. In late period or early period, whenever a patient comes, biliary complications, vascular complications, rejection, drug-induced liver injury, and infection. These are always a possibility at all time periods. So generally, complications follow a time frame. In first week, it is ischemic reperfusion injury, either primary non-function or early allograft dysfunction, small pore size, vascular complications, bile leaks, and sepsis. In second to fourth week, it is acute cellular rejection, sepsis, again vascular and biliary complications can be there, and it can be small pore size. But in first to 6 months, vascular complications are uncommon, and common complications are biliary strictures, acute rejection, CMV, infections. Chronic rejection can happen in first 6 months, but it is rare. So for some ischemic reperfusion injury, it ranges from mildly diseased LFTs to early allograft dysfunction, primary non-function. there is very little we can do after IR injury occurrence. So pre-transplant planning is important. This happens, so donor-related factors like hypernatremia, higher age, higher donor risk index, donation after cardiac death, obese donor, graft steatosis, more cold ischemia time, perfusion-related injury, distance to procurement, or recipient-related factors like multiple blood products use, higher MELD, severity of portal hypertension, higher age. So all these factors account in planning of prevention of IR injury, and a sick recipient should be given a good graft. So primary non-function, it happens in 2 to 5%. It leads to mortality or retransplantation. It is defined as highest priority listing for DDLT and defined as AST greater than 3000, INR more than 2.5, and then acidosis, pH low or lactate more than 4 in presence of so there should be exclusion of other causes, then it is labeled as primary non-function. Early allograft dysfunction, multiple definitions are given. It happens in 2 to 23% in various series. So this is a recent definition given in 2010. It is defined as bilirubin more than 10 on post-op day 7, INR more than 1.6, again on post-op day 7, and ALT or AST more than 2000 within first 7 days. In this particular series, 18% died in EAD group versus 1.8% in without EAD. So risk of mortality is 10 times. Two things have been tried for early allograft dysfunction. Prostaglandins, this basically they improve liver circulation. This is meta-analysis of 10 studies, included 652 patients. No significant effect on liver-related mortality, but some kidney protection effect. Another thing that has been tried in early allograft dysfunction is plasmapheresis. So 4 studies, all are retrospective, all are non-randomized. This study has largest number. It is from Asan, Korea, 107 patients in plasmapheresis group, 36 in non-plasmapheresis group. So mortality was 18% at 1 month and 47% at 1 year in plasmapheresis group. That was significant worse in non-plasmapheresis group. But we should not forget that retrospective is non-randomized studies. 3 of these studies concluded that plasmapheresis is effective. This last study showed it is not effective. Then small 4 size syndrome. It is defined as within 2 weeks of living donor liver transplant in presence of GRWR less than 0.8 and higher portal flow, bilirubin more than 5, ascites more than 1 liter per day, INR more than 2, for consecutive 3 days or at day 14 and presence of hepatic encephalopathy. And again, there should be exclusion of technical factors. So many things affect small 4 size syndrome occurrence and its outcome. These are cold ischemia time and warm ischemia time, portal flow, portal pressure, GRWR, graft steatosis, venous outflow, higher MELD, sepsis, portal hypertension, hepatic arterial flow shunts, and patient's performance status. So one thing that can be done to prevent small 4 size syndrome is portal inflow modulation to decrease portal flow. This is a study from Medanta. So if portal pressure is less than 15, we do not do any inflow modulation. If portal flow is more than 15, and in presence of low GRWR, either hemiportocaval shunt or splenic artery ligation is done. So with these measures, 4% patients had small 4 size syndrome in this series. Like PNF and EAD, prevention is important. Very little can be done in established small 4 size syndrome. In our series that I showed in last slide, 8 patients had SFS and 4 died. So there should be a good GRWR. If GRWR is low, donor should be young and there should be no steatosis in graft. Very little can be done in established SFSs. So prevention of sepsis is important. Good nutrition is important. And there is very little data on delayed splenic artery embolization or octride. Vascular complications, hepatic artery complications. So thrombosis happens in 2.9% in first month, and first to 6 months, it happens in 2.2%. It can be asymptomatic rise of enzymes, or it can be biliary complications, sepsis and graft failure. Hepatic artery stenosis happens in 2 to 13% of patients. Pseudoaneurysm generally present with bleed 2.5%, and rupture of hepatic artery generally from pseudoaneurysm 0.6%. Portal vein thrombosis happens in less than 3%. Venous outflow or IVC complications are uncommon. So these are diagnosed on Doppler ultrasound. If there is doubt on Doppler, then a CT angiography is done. Management is surgical or by intervention radiology. For hepatic artery thrombosis, generally, if we are not able to open it, retransplantation is required. Acute cellular rejection, it is diagnosed by liver biopsy. 3 criteria that are given 1, 2, 3 score each: presence of periportal lymphocytes or eosinophilic infiltrate, ductitis, and endothelitis. So differential diagnosis I have shown in earlier slides. Infection, vascular complications, they remain differential diagnosis always in a patient with graft dysfunction. And generally in mild acute cellular rejection, recommendations are to increase CNI. In moderate to severe, recommendations are to use steroid boluses. Early acute cellular rejection, it happens approximately 15% of cases. It doesn't affect survival and it doesn't predispose to chronic rejection. Standard immunosuppression is given in long run. So recurrent rejection or late acute rejection, there is risk of chronic rejection. In chronic rejection, 50% of patients respond to increasing immunosuppression, 50% require retransplantation. There is no universal definition of timing, how late is true late. Various studies have defined 1 month to 1 year as late ECR. This is Medanta experience published as abstract. So we found that less than 3-month acute cellular rejection, chronic rejection incidence is 2.5%. But after 90 days, whenever this late acute rejection happens, almost 14% or 12% patients, they develop chronic rejection. So in our setup, late acute cellular rejection is when it happens more than 3 months. It requires more immunosuppression in long run. Biliary complications, leaks happen in 2 to 15% of patients, generally present in first or second week. We can see a biloma on CT and drain bilirubin remains high. Surgery is done if detected early. Otherwise, a percutaneous drainage is placed and ERCP is done. Strictures happen in 10 to 25% of patients. Generally, they present with asymptomatic increase of enzymes. Occasionally, there is jaundice and pruritus, sometimes cholangitis. MRCP differentiate between anastomosis and non-anastomosis strictures, and endoscopy is generally feasible in these patients. If failed, then PTBD is needed. Drug-induced hepatotoxicity or interactions, it can happen anytime after liver transplantation. With rifampicin, level of immunosuppression decreases and there are chances of rejection. Antifungals, particularly azoles, they increase mTOR inhibitors or calcineurin inhibitors levels, and antibiotics, particularly erythromycin group, they are again associated with increased levels. So I present a case, 55-year-old male, NASH-related acute on chronic liver failure, LDLT was done. He had acute cellular rejection in first month and steroid boluses were given. Again, he presented with raised LFTs at 6 weeks. Bilirubin was normal, but AST 196, ALT 341, not so high ALP and GGT. So a standard workup for patients with liver graft dysfunction, it is liver Doppler, MRCP, viral serologies, TAC level. If TAC level is low, it increases possibility of rejection. Patient was on tacrolimus, mycophenolate, and steroids in tapering doses. So options are increasing dose of steroid or we do a repeat biopsy. So it is always important to do a repeat biopsy. Actually, this patient had CMV hepatitis. So these dots represent CMV IHC positivity. So sometimes we found uncommon diagnosis also on liver biopsy. Generally, it is acute cellular rejection, but sometimes we found chronic rejection also. And if there is acute cellular rejection, we go for bolus steroid. If it is chronic, then everolimus is added. Sometimes we have seen veno-occlusive disease, and it is reported with tacrolimus and MMF. So we need to stop these agents, and we start either cyclosporine. Then CMV hepatitis, I have shown just this case, antivirals are needed. In fact, there is decrease of immunosuppression needed rather than increasing immunosuppression in CMV hepatitis. So key home messages, early allograft dysfunction is actually common after liver transplantation. Evaluation is done for cause according to timeline of events. In early allograft dysfunction or small fore size, pre-planning is very important. Very little can be done after established EAD or SFS, and these things are associated with significant mortality. So general support, nutrition, prevention of sepsis is important in these patients. In vascular issues, early diagnosis can save life of a patient, and doing biopsy when all other things are negative is important rather than increasing steroids empirically. Thank you.
Thank you, Dr. Narendra. It was a very nice presentation. We have 2 minutes for questions, if there are any.
Dr. Narendra, can I ask you a question?
Yes, sir.
Do you find a difference in the post-transplant graft dysfunction when it is done in an emergency basis than in a planned way? So like a patient shifted to your center by an acute on chronic liver failure or acute liver failure, where you work up the patient as well as donors say within 24 to 48 hours and do an emergency transplant. And then you compare it with a transplant which you have done after proper optimization of donor as well as recipient. Do you find a difference in your post-transplant results?
Sir, in patients with MELD less than 25, more than 25, there is no difference, but very high MELD, more than 30, 35, yes, there will be a difference. So patients who are sick, high MELD, they have worse graft survival and overall survival.
Any other question from the audience?
Yeah, Naren, this is Dr. Hitendra. Am I audible?
Yes, sir, you are.
Naren, just a comment. I mean, if you elaborate all the causes of jaundice in first 6 months, I mean, we must see hepatitis B or HCV RNA in a patient when we do combined liver kidney, or in patients of sometimes there is occult hep C is there. So if patient develop a jaundice in even within 6 months, even 1 or 2 months, one should do, if we rule out other causes, we must do HBV DNA, HCV RNA also, just to see is there any occult B or occult C is there.
Hepatitis C recurrence is universal if pre-transplant RNA is present.
No, anti-HCV is negative. If anti-HCV negative, because we do not do HCV RNA routinely in a patients of pre-op. So we do anti-HCV usually. I mean, most of the center. So we try to find the cause. I think we must do HCV RNA and HBV DNA also, even if they are negative.
Definitely, sir. Because HCV RNA and HBV DNA, they are part of workup at our center. But if not done, then definitely should be done.
Okay, even if
thank you,
Dr. Sandeep, there is a question from an audience before we close this session. It is by Dr. Akash Rai. Are clinical endpoints more rational than the microbial endpoints? This is a question by Dr. Akash Rai.
I think this question is for Dr. Philip.
I think this just came up on the chat box right now. So I thought if Dr. Philip can answer this question, otherwise we can close this talk and we can move to the third talk.
I think we are getting late, so we move to the
third talk. Okay. Yes, Dr. Sandeep, go ahead.
Yeah, so the third talk is by Dr. Geoffrey Dosecco, who is a professor of medicine at University College London, and he is a consultant hepatologist at King's College Hospital. He will be speaking on newer diagnostic markers in hepatitis B He has a vast experience on this subject. Let us hear from him. Dr. Geoffrey, please.
Thank you very much, Chairman, and thank you to the Association for the opportunity to present. I will share my screen with a bit of luck. Is that sharing by any chance?
Yeah, go to the full screen.
Can you see that?
Yeah. Go ahead.
Thank you. So my topic is new diagnostic markers in hepatitis B, and I'm going to give a very brief overview of the subject. We know a lot about hepatitis B replication, and as a result, we have some very well-defined markers for studying and monitoring the disease in patients. And these include, of course, HBsAg, the diagnostic marker of hepatitis B, and hepatitis B DNA. Hepatitis B DNA measurement is fundamental to our understanding and monitoring of hepatitis B. But understanding the life cycle, we know that there is a critical residual template for hepatitis B replication, the so-called CCC or covalently closed DNA within the nucleus. Transcribed from CCC DNA is a large RNA species known as the pregenomic RNA, which is in turn reversely transcribed into the minus strand and plus strand of hepatitis B DNA. It turns out that some particles in serum will contain pregenomic RNA or hepatitis B RNA. We also know that several genes encoding for the core antigen are translated to form various forms, including E antigen and core antigen, giving us another useful composite marker known as correlated antigen, also found in serum. So we have two new liquid markers for studying hepatitis B. Just to remind the audience that hepatitis B DNA will exist as both integrated and replicated forms in the liver. It is a unique life cycle. We know that pregenomic RNA is transcribed from CCC DNA and results in the formation of hepatitis B DNA found in virions. The surface antigen also encodes the virions. But hepatitis B integrates into the host genome. This linear form of the hepatitis B DNA is not a part of the replicative cycle of hepatitis B. However, the integrated viral genomes and the subgenomic DNA found within these integrated genomes will transcribe subgenomic RNA producing HBsAg, particularly small spherical 22 nanometers. This does not play any part in the replicative cycle of hepatitis B, but encodes vast amounts of HBsAg that exceeds hepatitis B virions, providing a diagnostic marker, but also compounding the difficulty because surface antigen can be obtained from both integrated as well as CCC DNA. So firstly, I'm going to briefly remind you that hepatitis B DNA is the useful marker that we're familiar with. It is clearly the most important marker for understanding replication of hepatitis B. It is easily measured by serum PCR. We have a number of point-of-care tests now available in India that will enable us to add hepatitis B DNA to every HBsAg positive patients. I don't have time to detail all the prognostic and diagnostic information that pertains to hepatitis B DNA, but this slide shows, for example, that there is a very strong relationship between levels of hepatitis B replication measured by hepatitis B DNA and the subsequent risk of hepatocellular carcinoma or cirrhosis. HBsAg concentrations are clearly important. Again, in the interest of time, I'm just going to focus on one or two salient aspects. We know that HBsAg, as I pointed out, is derived from both CCC DNA and viral particles, as well as from integrated viral genomes. As one would expect, HBsAg concentrations are usually highest in the E antigen positive patients with active virus replication, but we can find copious amounts of defective 22 nanometer HBsAg particles in E- patients even in those who have low rates of replication and low DNA concentrations. We know that in the E-negative patients, generally speaking, HBsAg concentrations are lowest in those with very low replicator states, suggesting that the only source of HBsAg in such patients, the inactive carriers, is in fact integrated hepatitis B DNA. And that explains the problem. We can quantitate HBsAg. It's a useful marker of prognosis. There is an association with the later risk of primary liver cancer, for example. It is the target of functional cure. But we know that in e-antigen positive patients, there is a linear correlation between concentrations of surface antigen and cccDNA, because much of the surface antigen is in fact being derived from cccDNA. In the E-negative patient shown in blue, however, there is no correlation between surface antigen and cccDNA, because most of the surface antigen in the E-negative patients, the older patients, is derived from integrated viral hepatitis B DNA. Hence the need for newer biomarkers which will give us an indication of transcription from cccDNA, whether in E-positive or E-negative patients, or merely transcription from integrated viral genomes. The first of these markers is the hepatitis B core-related antigen, or HBCR antigen. This is clearly a marker, as I'll show you, of cccDNA transcription. Core-related antigen can only be derived from cccDNA. It cannot be derived from the integrated linear subgenomic integrants of hepatitis B DNA. And its finding in serum informs us that cccDNA transcription is active. It is actually a composite marker of E antigen, the core antigen, and a unique pre-core protein P22. It's a good marker in the DNA suppressed patients for ongoing transcription, and we do have commercial tests available for measuring core-related antigen, and tests with more sensitivity are being developed. Once more, to explain to you that pregenomic RNA, shown here, can only be derived from cccDNA. It is a full-length RNA. By using primers to only hybridize to the full-length RNA, we can ascertain that RNA in serum is derived from cccDNA transcription and not from the smaller RNAs that are transcribed from integrated viral genomes. And we know that core-related antigen is derived from the core and pre-core gene translation with various post-translational modifications. Clinically, we can show that, of course, as you would expect, the core-related antigen is highest in the E-positive patients. This is shown on this graph from two studies. It's not a very useful marker in the E-antigen positive patients, as they're already E-antigen positive, have high levels of DNA. You would expect high levels of core-related antigen. Core-related antigen is found in E-negative patients with active hepatitis B, and these patients are generally DNA positive before receiving antiviral therapy. And it is more difficult to find core-related antigen. It is usually present, if at all, in only low concentrations in the inactive carriers, suggesting little transcription from cccDNA as opposed to these phases of hepatitis B. A recent study published by Ghani et al. In Hepatology has confirmed this in most of the immunotolerant E-positive patients and the immunoactive E-positive patients, as shown in the orange color. Core-related antigen was present at high concentrations. But at the other end of the extreme, the inactive carriers, or E-negative, with low concentrations of hepatitis B DNA, core-related antigen is present only at low concentrations or below the limit of quantitation, as shown in the green column. There are indeterminate phases, and perhaps we need to think about not how we fit these markers to phases, but how we fit the phases to these new markers. In the context of antiviral therapy, when nucleoside analogs are given to patients, as we showed in this study, in patients, some of whom underwent E-seroconversion on nucleoside analogs versus others who did not. As you'd expect, the HBV DNA concentrations decline, as shown by this lower bar, but the correlated antigen and surface antigen did not. There was a difference in the E-antigen seroconverters. Here you can see, as you'd expect with antiviral therapy, the hepatitis B DNA concentrations declined, but did not distinguish those who later lost E-antigen. But there was a subtle difference in the rates of core antigen decline, the dark gray boxes, in those who subsequently lost E-antigen. Also, these differences can help us perhaps in stopping nucleoside analogs. Here we studied E-antigen negative patients who stopped nucleoside analog therapy. As you'd expect, the hepatitis B DNA concentrations were suppressed in all these E-antigen negative patients who received antiviral therapy. Surface antigen concentrations did not help us. They were the same in those patients who did not flare after cessation or who did flare. But we did find higher concentrations before stopping treatment in the E-negative patients who did have flares, and we showed higher pregenomic RNA also in these E-negative patients who subsequently flared. So to close with, I'm going to briefly mention pregenomic RNA. This again is a new biomarker. It is a good liquid biomarker of cccDNA transcriptional activity in serum. It's very difficult to measure cccDNA in liver. It needs a biopsy or fine needle aspiration, and the techniques are not standardized, but we are getting to a good liquid marker of transcriptional activity. Correlates with the intrahepatic pregenomic RNA and, as you'd expect, cccDNA. It can be detected during nucleoside analog treatment after the DNA becomes undetectable, indicating some of these patients have ongoing transcription. By using specific primers and probes to measure the cccDNA-derived HBV, we can be sure we're not measuring RNA from integrated viral genomes. And again, we have a test for cccDNA. Commercial tests are in development. And here are a few clinical examples. Here are the serum HBV RNA concentrations in immune-tolerant E-positive patients, high as you'd expect. In the E-positive patients with immune-active disease, a little lower but higher, but lowest of all in the inactive carriers. And again, from the same study that's recently been published by the NIH group, you'd expect pregenomic RNA to be highest in the E-positive immunotolerant patients. It is, again, fairly high in the E-positive immune-active group, but it's lowest of all in the inactive E-antigen negative carriers, suggesting some of these individuals have either lost cccDNA or have silenced cccDNA, and there's very little ongoing transcription. Again, this group tried to fit these markers to the phase, but in the future, we might want to fit the phases based on these markers. And we can, I think, begin to fairly safely say that a reduction in cccDNA transcriptional activity can be recognized in some individuals. We'd like to get there with antiviral therapy. Many of these patients are DNA negative, but by finding low levels of pregenomic RNA, we can assume that these patients have silenced their cccDNA and are truly inactive with a good prognosis. That's where we'd like to get to with antiviral therapy. So just to remind you, on current nucleoside analog therapy, as we studied at King's College Hospital, at baseline, in E-negative patients who were DNA positive, a very high proportion, of course, shown in blue, had pregenomic RNA, and shown in red, correlated antigen, and were by definition DNA positive before starting antiviral therapy. At year one, many were DNA negative, but substantial proportions through year one, year two, and year three, and at the time that we withdrew nucleoside analogs, although they were HBV DNA undetectable, effectively suppressed with nucleoside analog suppression, substantial proportions still had pregenomic RNA at year 2 and 3, shown in blue, and correlated antigen. And perhaps we shall learn that we should not stop nucleoside analogs in those patients because of the very high likelihood of relapse or even a severe flare. So in conclusion, we're not able to detect markers of hepatitis B integration in serum, It remains essential to measure hepatitis B DNA levels in all HBsAg positive patients to monitor their course and to decide on antiviral therapy. Using newer serum biomarkers, we're getting to the point that we're able to measure cccDNA transcriptional activity, and we could refine these markers to further determine the phase of disease, the natural history, and course on antiviral therapy. These markers could prove to be valuable utilities within the natural history of chronic hepatitis B and assist in defining the state in patients, and they're clearly being used to define target engagement with newer potentially curative therapies in the nucleoside analog DNA suppressed patients, such as the capsid inhibitors and RNA interfering agents. Once again, thank you for the invitation.
Thanks, Geoffrey. It was a very nice talk. As we are getting late, so I'll request Dr. Ajay to actually go to the other talk, introduce the speaker. Thank you, Dr. Geoffrey. Thank you.
Thank you.
Thank you, Professor Jaffrey, and thank you, Dr. Nichavan. The last talk in this session is by Professor Subhash Gupta, who is one of the pioneers in establishing the liver transplant program in this country in about 20 years back. Currently, he is associated with Max Super Specialty Hospital as director of the liver transplant program. And today he will be speaking on acute liver failure, the role of liver transplantation and Indian experience. Professor Subhash Gupta, please.
Thank you very much for giving me this opportunity to speak. And I'll just take you through my slides. I think I can share them now. Can you see my slide? Am I able to do the screen share?
Yeah. Go to full screen.
Okay. So welcome to all my chairpersons, and thank you once again for giving me this opportunity to speak. So I thought my talk was on lessons learned from Indian experience. And therefore, what I've done is I first looked at why and how acute liver failure and liver transplant for acute liver failure is different here than in the rest of the world. So I found there were 4 main differences. One was difference in etiology. And of course, as we know, there's a lack of organized healthcare system in our country. There's a sort of plethora of prognostic criteria, which unfortunately none of them have been validated in transplant centers. Many of them have been derived from our own sort of population. Then when we come to acute liver failure management in our ICU, there is a deficiency in measurement of intracranial pressure and how to go about it if the pressure is raised. And finally, we all know living donor liver transplantation is the major form of transplantation in acute liver failure here as compared to the West. So I will not dwell too much on the etiology, but just to highlight what has been reported and experienced by us. Paracetamol overdose is uncommon. Hepatitis E, A, and B infection continue to be there. ATT drugs, but the incidence is going down as there is great awareness that these drugs may cause liver injury. Herbal medicines, and we'll talk a bit more about that, particularly Giloy, rodenticide poisoning, and patients on chemotherapy will occasionally have reactivation of suppressed chronic viral infection and unusual viral infections such as dengue causing acute liver failure. As I said, paracetamol overdose will skip, uncommon. In 20 years that I've been here, we've only seen 3 patients who had paracetamol overdose. 2 were ex-UK residents and 1 was a nurse. And King's College criteria is well established for selection of patients. What about other etiologies? Hepatitis E is probably the commonest etiology still. An outbreak of hepatitis A as well is reported every now and then. And the incidence seems to shift from children to teenagers as children move out of protective environments of their home to their hostels or workplaces. And fortunately, overall seems to have better prognosis and lesser requirement for transplantation. In the past, hepatitis infection pregnancy was thought to be a disastrous diagnosis, but currently it seems that it may have similar prognosis. One of the problems we faced for diagnosing hepatitis C, and we can, of course, learn at panel like today's, we can discuss this. Testing for hepatitis C is not standardized. There's some reports of cross-reactivity with Epstein-Barr virus and CMV virus, the different sensitivity and specificity with different assays in the market. Hepatitis C viremia is very short-lived, so PCR can be falsely negative. There's high seroprevalence of hepatitis C infection, and IgM positive may last for 6 months. Many patients are fine, who are labeled as having hepatitis C infection, the diagnosis cannot be certain just based on the markers. Hepatitis B infection remains occasionally there, particularly with use of chemotherapy and reactivation. And often we end up with a situation where someone who was responding well to adjuvant treatment for cancer has reactivation of hepatitis B and fulminant liver failure. And then we are in a dilemma whether we should transplant them or not, because obviously we have recent malignancy, then risk after transplantation is magnified. But we've done 2 such patients, and luckily both of them seem to be cancer-free. ATT drugs, and one of the important things that I would like to say here is that what we've seen that patients who have advanced decompensated cirrhosis, we should not because even if we did try to decompensate and they tolerate the treatment poorly, at the same time, we should be sort of aware that TB may cirrhosis, particularly with alcoholic cirrhosis, malnutrition, and if post-transplantation, if there's evidence of TB, then they should be treated almost immediately. Herbal medicines are pretty much during the pandemic have been widely used, and Giloy particularly has been reported by Dr. Abha Nagral as mimicking acute immune hepatitis and fulminant liver failure. And we certainly have had experience of one case with fulminant liver failure from Giloy. There's some confusion regarding whether it's Stenospora cordifolia or CRISPR, which one causes it. And at the moment, the controversy is ripe because there are competing groups saying that this is a wonder medicine, while some of us hepatologists and transplant surgeons feel that it may cause liver failure. Rodenticide poisoning is common in South India. Some reports with success with plasma exchange, but the LTSI published guidelines regarding management, which was if the INR is greater than 6, MEL greater than 36, persistent lactic acidosis, or any encephalopathy, then they should go through transplantation. There have been unusual viral infections as well, which is acute liver failure, and we reported one liver transplantation last year. Liver transplant for dengue liver failure. Dr. Amna Purkar, we miss him a lot, divided acute liver failure and why if to where it was an infectious disease, but not a non-hepatotropic virus. But unusual because most of us know that if the prognostic criteria, when the etiology is not known, that we see. We will if you liver failure, it's possible have POA because they come from the same family and background. One aspect, which is lack of organized healthcare. Patients, as we know in our country, choose doctors, hospitals, and even treatment plans for themselves. If they're okay with the transplant option, they'll end up with a transplant surgeon. Centers are either active as hepatology groups or as liver transplant centers. And we find often that a bias appears in the treatment plan for the patients. We've seen a lot of myths about liver transplantation patients. Sometimes they feel that liver transplantation is the last option, not the appropriate therapy. And sometimes the problem is made worse as King's College criteria for viral diseases, not as good, may have low sensitivity. That means patients who are thought to improve on their own will actually die from liver failure. There is a need for better selection criteria. And you'll find that many non-transplant centers, hepatologists have reported that patients often recover from encephalopathy, but die from infection later on. Possibly the necrotic regenerative liver is a nidus for infection. There's also misconception about costs of living donor liver transplantation. Most patients think it's upward of 50 lakhs. And donor selection criteria is sometimes too stringent, as in the short time that is available for legal clearance, only near relatives can donate, and they may not be of the correct blood group or may not have a liver of good quality. So prognostic criteria, number of them, I don't want to go through that. King's College criteria, we're all familiar with it, but no discussion on ALF can be complete without talking about King's College criteria. And I'll stick there, but what I'd like to highlight is that prognostic criteria of King's College, it continues to have universal popularity, though the sensitivity is low, but seems to be the accepted standard for listing for cadaveric transplantation. In the context of LDLT, where donors usually accompanies the recipient, dynamic criteria such as the one published by Dr. Acharya's group may be more appropriate. Cerebral edema may be the most clinching factor in decision making, and cerebral edema is the grade of encephalopathy is related to the extent of edema, hypertension, bradycardia, neurogenic hyperventilation, dilated pupil, decerebrated posturing, and seizures. And what we do at our center, if we see a cerebral edema, then we would like to go ahead with transplantations. And numerous authors, Dr. Dhiman, Dr. Charya, they've all shown that cerebral edema has a poor prognosis. Also, if the person has concomitant lung and renal impairment, again, transplant-free survival is poor and they'll be expedited for transplantation. All the others will have a focused ICU care with dynamic assessment over 72 hours. So monitoring intracranial pressure has been difficult. We've been difficult to convince neurosurgeons and in fact to convince ourselves as well to do intracranial bolt placements and measurement of pressure. And generally, it's not widely popular, though at one time when I was a new kid, it was done in almost all patients. We looked at other methods for measuring intracranial pressure, but optic nerve sheath diameter and middle cerebral artery pulsatility index and transcranial Doppler, they all have shown promise in research tools, but on bedside, they've not yielded favorable results. So what we end up doing is that if you have a person for transplant, we'll do a CT scan prior to shifting to theater. Either severe edema, such as you can see here, the gyri and sulci have been effaced, and this compression of ventricles, then we will not go ahead with transplantation. The bean causes a poor outcome after liver transplantation, mainly infections and neurological complications. This is reported from many centers, including from India. Dr. Pamechan's group has shown that infection, neurological complications are the key factors for poor results. Finally, at the end of my talk, we'll talk about living donor liver transplantation versus diseased donor liver transplantation. This has been obviously reported cases of good outcome, as these are young patients, previously healthy. Heroism and ethics of value, timing of liver transplantation can be accurate, but minimal time to evaluate patients, donors, and families under extreme stress, no cooling off period, pressure for accurate donation is an outcome is poor. But LDLT gives good results. So finally, in the last 2-3 slides, liver transplantation ALF, when not to proceed, compromised brain functions, fixed dilated pupil, rapidly escalating inotropes, marked respiratory failure, inability to tolerate a long procedure. When it is okay to go ahead, college criteria fulfilled, etiology is not, it is independent of acute liver failure, absence of irreversible brain injury, and ability to follow post-transplant restriction. When is it okay to wait? Patients obviously showing sustained improvement, acute liver failure, and severe acidosis, elevated lactate response rapidly to resuscitative measures. Most patients when the liver allocated is marginal, especially steatotic, non-ABO identical or split ABO incompatible, or in diseased donor liver transplantation if the donor is greater than 6 years of age. So we have about, from our over 3,000 transplant, 5% of acute liver failure, and now increasingly we do a lot of ABO incompatible liver transplantation. And even in the pandemic years, our numbers didn't go down much. And finally, in summary, what lessons did we learn from our program and from our other workers within in our country? In the Indian context, viral etiologies, ATT drugs, herbal medicines, rodenticide poisoning are the main culprits. There's bias for transplant centers and focus on medical management in hepatology-led centers. King's College criteria continue to be popular. Indian criteria have been not been validated by transplant groups. Intracranial pressure monitoring in its infancy, and living donor liver transplantation dominates over diseased donor liver transplantation in ALF. Thank you very much for your attention.
Welcome to my gully. You must be wondering, is it a gully boy scene or not? No, this is my birthplace. This is where I was born. I grew up from here. And within 3 years,
Yeah. Thank you, Subhash. It was an excellent presentation. We are very sorry we are not having much of discussions because of lack of time. I'd like to thank all the speakers who did excellent job and doing justice to their topics with a very good carry-home messages. I'd like to thank my co-chairs for assisting the session. Now the session is over to Dr. Kaushal. Thank you very much.
Thank you, sir. So this leads us to the final session, an important session, Pediatric Hepatology course. I welcome the course directors, Dr. Neelam Mohan and Dr. Seema Alam, to take us through this wonderful course. And the chairpersons I will also welcome the chairpersons for the first session, who are Dr. Malti Satyasekharan,
passion and build a business around.
pediatric
You want to know how?
MGM,
Click the link, join the masterclass, which I've exclusively designed for people like you who have been in poor families, born in poor families, raised in a middle class,
and
you want to become rich, you want to follow his passion, you want to have time for him. This
Head, Professor and Head, Pediatric Hepatology, ILBS Hospital, New Delhi.
Thank you, dear, for that introduction. It's a pleasure, and we would like to thank INASL for this opportunity given to the Pediatric Forum. And today we have all the stalwarts in the field of pediatric hepatology joining us for this session. And I would request the chairpersons, Malati, John and Seema. I assume they would have joined. I would request them, Malati, to introduce the first speaker for today. That is Naresh.
Good evening. Thank you, Dr. Neelam. Thank you for that introduction. And yes, we have come to a very interesting session. And the first speaker for this session is none other than Dr. Naresh, whom we all know. He is a senior consultant and clinical lead, pediatric liver and GI director, women and children health at the famous Dr. Rela Institute and Medical Center in Krompet, Chennai. He's been abroad for several years, but now has returned to his motherland to work for us and for all the children. And he is going to talk on a very important topic on bile transport disorders. And I think he will talk to us something new. Though we've allotted you 13 minutes, Dr. Naresh, I think Dr. Anil could not make it for today. So maybe you could extend for another 15 minutes, 2 more minutes.
No, Malati, we had decided that we'll stick to the time that we planned.
Yeah,
it is the discussion we will do in the end.
Okay, but probably let's see.
So they'll stick to their time.
Okay.
Thank you, Dr. Malti. I would like to thank the INASL chairperson and the directors for this session, Dr. Neelam, Seema, Dr. Malti, Dr. John. Let me jump on to the topic. So shall I share the screen? So I have been given the topic on expanded presentations of transporter defects, bile transporters defect, which essentially we are talking about a group of genetic disorders called the progressive familial intrahepatic cholestasis, where the bile is not secreted appropriately from the hepatocytes, and it causes a lot of issues. When we say expanded presentations, it essentially means the presentation of this disorder is quite varied, and it can be from simple neonatal cholestasis to undiagnosed cirrhosis in an adult. So I'm going to go through in next 13 minutes what has happened and how we have evolved over last 10 years. Before 2010, we don't have immunostaining, and the Kings were doing it from 98. And few presentations that happened at 2009 or 2008 based on genetic study, and also from CMC Vellore, they do the electron microscope. So there are only few presentations. In 2011, we conducted a small meeting for the histopathologist, and Professor Bernard Portman from King's College came around, and he showed them how to stain for this PFIC receptors. And after that, quite a lot of centers have started doing it, and now we have quite a lot of case series and case notes coming out of this progressive familial intrahepatic cholestasis. So as I said, it's a group of autosomal recessive disorders, and it can present from neonatal age to even adults. And the incidence is roughly 1 in 50,000 to 1 in a lakh, and it accounts for nearly 9 to 12% of all neonatal cholestasis. So jumping on to the types, essentially the types are growing, and the knowledge what we have is still limited, and still we are looking at things. To start with PFIC type 1, there is a receptor called FIC1 receptor, and you have a genetic defect on the gene ATP8B1, and FIC1 receptor you see here, but to date, there is no antibodies diagnosed for this FIC1 receptor. So when a histopathologist look into the specimen, we don't have a FIC1 anti-FIC1 receptors to tell them. So essentially, they look at the gamma GT in the expression in them and the bland cholestasis, and they comment on PFIC type 1. Coming on to PFIC type 2, which is called the bile salt export pump deficiency, and yes, it has a receptor and an antibody, and we can diagnose it quite precisely, and it pumps out the bile acids from intrahepatic to the biliary canaliculi. And then comes MDR3 deficiency, which is also called as PFIC type 3, where it strictly not exporting bile. It exports some form of phospholipids, and which helps in bile formation and secretion. And this is due to mutation in the gene ABCB4. And again, the presentation is quite varied, which I will be touching on. Then more recently, we have come up with PFIC type 4, which is tight junction protein defects, where the junction between the cells is not good, so that there is an issue with bile acid secretions and cholestasis. And then we have FXR mutation and MyoB, which is still in an evolving stage of diagnosing it. So the basic problem in this, in few of the disorders, has low gamma GT, and that is quite classical. Not every disorder has low gamma GT. There are only very few conditions in pediatric neonatal cholestasis which has low gamma GT cholestasis. To tell everyone, at newborn, the normal gamma GT is around 300. It's not 50, it's not 40, it's 300. So even a gamma GT of 15 with cholestasis in a newborn, less than 1 month, 2 months, is actually a low GGT cholestasis. So we have type 1, type 2, type 3, type 4, type 5, and still we haven't named it as type 6, the myosin 5B defect. So FIC1 receptors, when there is absence of this FIC1 receptors, results in increased bile acids within the cells, which downregulates the FXR receptor, and in turn it downregulates BSEP receptors, and in turn it downregulates the CFTR receptor. So quite a lot of mechanism happening, and these receptors are expressed in small intestine, kidneys, pancreas. So it is a generalized disorder. It is not just limited to the liver. So you can see this child, quite short, itching, scratching all the time. The presentation, as the topic is given to me, you can be presenting with sensory neural deafness, pancreatitis, like a wheezy child. These are some of the presentations. And then we looked at a spectrum. This is a disease spectrum, and children can present with what we call BRIC, benign recurrent intrahepatic cholestasis, where they have severe cholestasis, and in between the periods they can be absolutely fine. And you have transient neonatal cholestasis and intrahepatic cholestasis of pregnancy. So these are all the varied presentation of this PFIC type 1. Biliary diversion is the treatment, which I'm not going to talk about. And when it comes to transplant in PFIC, there has always been a debate that it causes steatosis and the graft loss. But more recently, we have started doing this total internal biliary diversion, where we connect the rule loop directly to the ascending colon. And I'm going to show a case where what happened. This is a child who was diagnosed with the PFIC type 1 and had a partial internal biliary diversion, but the itching was quite persistent. We did a transplant here, and then after transplant he was fine, but he had a bit of diarrhea, but also the enzymes were always quite high. So we did a biopsy. It shows a lot of fat in the histology. We have been monitoring him. A repeat biopsy after a couple of years, more fat. After nearly 5 years of transplant, fibrosis and fat. At this point, we did this total internal biliary diversion, and this is the graft after 1 year. There is a total reversal, and the fat is gone, and the fibrosis also disappeared. And we published this few months ago in our INASL journal. And then treatment for this BRIC severe cholestasis, we can do plasmapheresis, or we can try this nasobiliary drainage. You can see the poor quality of bile. This is just actually to break the cycle. People say breaking this cycle actually helps these children to get better. Moving on to type 2 PFIC, again it's a low gamma GT cholestasis, young presentation, quite young age. The classical feature is a giant cell hepatitis on biopsy. Sometimes people mistake this biopsy as giant cell hepatitis and tell the parents that it will get better. But when you immunostain them, you can find that there is an absent BSEP receptors in the cells. And again, this one has a milder forms, variants where BRIC2, ICP2, they can cause drug-induced cholestasis, transient neonatal cholestasis. So it's a totally a varied presentation. Type 3, lot of adults now looking into idiopathic cirrhosis. Now they are trying to see whether it is all MDR3 deficiency. And this can present from neonatal age to adulthood. And these are the varied presentations of PFIC type 3. You can have cholestasis in pregnancy, gallstones, intrahepatic gallstones, drug-induced cholestasis, adults with idiopathic cirrhosis, and transient neonatal cholestasis. So as I said, it's a spectrum varied from one end to the other. And this is our first publication on MDR3, 10 cases. TJP2 deficiency, more recently we have started seeing these patients. They present similarly to type 1, severe pruritus, growth failure, portal hypertension. And Dr. Malathi might know one of the patients who has undergone internal biliary diversion, thinking that it is type 1. And so far we have dealt with 4 cases. 3 of them has a homozygous mutation who has synthetic failure, while one child who has a compound heterozygous has a preserved synthetic function. You can see it is something similar to what we see in type 1 children, where they have growth failure, short stature, thick skin, and you can see the liver. It's a micronodular cirrhosis full of bile plugs. And this is our publication showing that you can get hepatocellular carcinoma in quite young age with this TJP2 deficiency. Coming to this type 5, what is quite interesting is even Dr. Alex Nicely, who's a well-known histopathologist, they used to stain for this BSEP receptors, and they have labeled a few of the children who has been having cholestasis, severe coagulopathy, quite young age. What I'm talking about is 1 month of age, 2 months of age, and they have been labeled as type 2 PFIC. But more recently, we have found out that these are actually children who had this FXR mutations. This FXR mutation, as I showed initially, can downgrade your BSEP receptors. And in histology, you might not find BSEP receptors. And this presentation is like 2-month-old, 3-month-old with a disproportionate coagulopathy. And as I said, biopsy might be mistaken for BSEP deficiency. And this is our experience. I think this is the last slide. Over the last 10 years, we have transplanted nearly 46 children with PFIC. 1 year survival, as I said initially, is 72%, and we have learned a lot from in dealing with these children with PFIC. Now we do total internal diversion at the time of surgery itself for this PFIC type 1 who has genetic diagnosis. And PFIC type 2, the survival is quite good. And the problem with PFIC type 2 is they can develop antibodies, and which can cause trouble, but still they do well. Catch-up growth, 25%, only 25% actually had a catch-up growth in PFIC type 1, while nearly 57% had a good catch-up growth. I think this data is yet to be published. And with this, I would like to conclude my talk. And this is a child, quite severe cholestasis. We have been debating about whether to transplant or not. That was in 2010. Yes, we did transplant. This is just 5 days after. And you can see the smile. The itching is totally gone, and this child is quite happy. And with this, I conclude my talk. Thank you.
Thanks, Naresh, for that. I have a question to ask you about this new drug, Odivixabat, because that got FDA approved. What are your thoughts on that?
Sorry, Neelam, I don't have any personal experience in handling those cases. I think probably somebody in the group who has.
Can I just chip in and ask a question, because even I don't have any information on that. But Naresh, I think it's an excellent presentation. We need to, for the sake of our young colleagues here, we need to be a little more, kind of talk about something that you have mentioned, which was not earlier mentioned by many people, and that is transient neonatal cholestasis. And we need to dwell a minute or two on that. And if you can tell us that, how do you differentiate with, and when do you really get to know that this could be a transient neonatal cholestasis? How do you think they have described this? And which of these PFICs are more likely to have transient neonatal cholestasis?
I think type 2, type 3 has been sort of shown to have this transient sort of cholestasis rather than type 1. And as I said, it's a quite varied disease. Still, we haven't understood the whole thing. I think we are looking into the genetics, the presentation. I'm pretty much sure with the incidents what they are quoting, there are a lot of people in the community who hasn't even been diagnosed with this problem. So it is a disease with a wide spectrum, which can be a slight itching to sort of quite severe disorders. So I'm not sure sort of how to define these cases.
Okay, there's one question that we need to, we'll put forward here, is that your comments on the variable penetrance of TJP2 gene resulting in a spectrum varying from CLD in a young child to a mild transaminitis in a adulthood. Please opine.
TJP2 deficiency. Now I told about 3. TJP2 deficiency, we have truncated mutation where where it's a compound heterozygous, where the child don't have failure but had sort of liver disease, itching was there, but the rest of these 3 children who had a homozygous mutation had severe itching with synthetic failure.
Okay, one more question that I would like to ask you, because of a patient of ours, is when you talked about the total intestinal biliary, internal biliary diversion in a patient of PFIC1 post-transplant. So what was your indication, and how long later could you do it? I mean, what was the description of the patient? Is just ketosis that the child had, or he was also having diarrhea at that time?
This child is having, I think this paper was published a few months ago in
I have seen that paper. I just want to be a little more.
I think this child had a short stature. This child had diarrheal episodes, 7 to 8 episodes every day, and also the enzymes never settled. So monitoring the immunosuppression was quite difficult for us. So always we have to keep the immunosuppression slightly high, even though we do a biopsy and say that there is no rejection. So after 5 years, we did the diversion and actually shown that even the fibrosis, what we have seen, has reverted back. The fat has totally disappeared. I think you would agree with me. We have a group of children in PFIC1 where they are quite short, severe rickets, itching, diarrhea, and you can actually differentiate this phenotype physically by seeing. Not I'm talking about genotype. Physically seeing this patient, you can tell these guys. And these are the children who would definitely benefit by this diversion surgery at the time of transplant.
Okay. No, my last question, if Dr. Aarti and Dr. Malati and Dr. John want to ask any questions, I'm just rushing with one more question, and that is this, that how much, I mean, there is always this debate regarding whether the patient has a compound heterozygous and does he only have a heterozygous or is a homozygous. If he's a homozygous, people are okay with that this is a pathogenic variant and you accept it. And my question to you is that if you have a child who's shown at least 2 or 3 typical episodes and he's in heterozygous and he's an older child,
No, I think the genetics is something which I think we need to keep it away. Genetics correlation, phenotype, genotype correlation, they have shown there is like quite a huge variation in genotype, phenotype correlation. I would go only on clinical grounds, not on the genetic grounds. Whatever the genetic thing is, if the child is fine, I'll happily leave the child and I wouldn't bother even touching. Because the genetics has become cheaper and we are finding lot of stuff, and probably only those who clinically has problem, I would touch them.
Okay.
But in fact, when you ask Richard from Thompson from UK, he said that there are PFIC2 some genes which they've identified where there is recurrence and they do very bad post-transplant. So that is why a lot of people are trying to look at genes because they know that some genes really bad. But I agree with you totally. We are not in that state right now to take a decision whether not to transplant or transplant when the patient clinically needs, and you need to tell the parents about it, that this could occur when, as you said, you had to do a diversion post-transplant to justify what you did. So I think we need to move to the next talk. Has Dr. Rohit Kohli joined us? Rohit?
Let Dr. John take up.
I don't know if Rohit has joined because there's no sign of him.
Okay, I'll just call him up again. He said,
Can I just ask Dr. Naresh a question with that? Yeah.
Yes, Dr. Malti, go ahead.
Dr. Naresh, I think in your list of transplant of 46, you had done quite a number for PFIC1 also, no?
Yeah.
But general teaching is, I mean, they don't do too well, they will not grow. For your indication, what was it? After diversion, you did it, or what was the thing? And what do you tell these people that they will not grow even after transplant? What will you?
No, I think always there is a debate when it comes to PFIC type 1, whether to transplant or not to transplant. But at the end of the day, these parents suffer a lot. And even when we tell them like there is only a 50% chance that your child might survive or whatever, they actually take up that option. I think at present, there is no way, there is no literature saying that we can't take away. And I think we are trying to improvise based on our experience, our own experience, and we are moving on. Looking at this total biliary diversion, I think there are only hardly 2-3 papers available. Essentially, now we have made it as a standard practice for all genetically proven PFIC, particularly the types where I told you, the short ones, severe itching, diarrhea, those guys would do definitely better with this thing.
Some symptoms, they might not grow,
Naresh,
but should we be earlier?
Naresh, should we be doing a biliary diversion early?
Yes, I think the indication for biliary diversion in these children is they should not have synthetic failure. They should not have portal hypertension, and essentially we do an endoscopy to make sure they don't have portal hypertension and like other indices like a large spleen or anything. Yes, we can try them. The success rate, I think we have published nearly 50 to 60% would be the success rate for biliary diversion. But definitely, yes, it is an option for children. I think first we have to offer. I think if they are not in synthetic failure, we do offer the biliary diversion as the first indication.
No, no, is that really the message, that to say that if you have PFIC type 1, you should do an internal biliary diversion before the liver functions deteriorate?
Yeah, definitely. I think
itching,
with itching, if there is an intractable itching and the medications, whatever we have tried is not helping, I think first step, I think we have to go for an internal biliary diversion. Again, I think there might be a debate about genetics saying this can be beneficial or might not be. But I think just giving the chance to this child to see whether they can live with their own liver.
So for PFIC1, I think there is no confusion regarding any genetics caused. I mean,
PFIC type 2, there is.
Well, I'm not talking of type 2. You said about type 1. Definitely, you've done a great job in the last patient. One more question that one of the students has posted is that can we antenatally prognosticate the type of PFIC in patients with ICP?
That's going to be
with ICP.
That's going to be difficult. Again, I think we need to do antenatally the genes, and again, even if we know the genes, whether there is no phenotype genotype correlation. So actually, we don't. But if they have a child with type 1 or type 2, where they have.
But I think Naresh, it is well known by now that 2 and 3 are more likely to be associated with. And FXR we don't know any.
It's not 100%, so it's a very small proportion, but it's high. But I have been following up, and even the children don't have PFIC. So I think we should follow up all these cases to see what is happening in India. I also want to know, Naresh, regarding this BRIC. So like you said, expanded bile salt transport. I think BRIC also cannot be taken lightly. So have you done diversion or transplant for these?
No, I think we have, I don't know whether you have seen this child. This child, I think, been following for 6 years. He get an attack, like each attack goes to the bilirubin goes up to 45, either we need to do plasmapheresis. I think you would have met this patient. And I am seeing that this child, every attack is much more severe than the previous attack. So far, I don't think we have.
Actually, that was the thing we published also. BRIC.
So what is his? What is the genetics?
I think he is PFIC type 1. Genetics 1.
So I think we may have to do a transplant because they go and take some CAM native medicine and we lose. I've lost one of those adolescent boys. I think that's what we published.
What about diversion, doctor? Both of you. I mean, why not diversion?
I think we have discussed with the parents saying that diversion we can offer, but there is no literature. The first question they ask is like, what is the evidence and all those things. When you say there is no evidence, they say like, why can't we wait? So I think this child, I think Dr. Malti, I think they would be in
40 milligram. It's so frightening. No, sending them for plasmapheresis. We lost that one child because of that. So I think BRIC also we cannot take it as it's benign. It's not benign.
It's not a benign condition. I would say it's not a benign condition.
In a small group, in a subset. I think Dr. Yacha has something to say.
Naresh, you have to tell us briefly now what is the message on the management of PFIC. Brief lines, and also highlight on the fact that whether we should do internal diversion or external biliary diversion.
I think
or PFIC1, you let us say which is PFIC, what is the management protocol?
I think the disease based on the spectrum. Medically, if the child is fine, leave him. If medically still itching, no synthetic failure, go for the diversion. We have discussed with parents about both internal and external. Invariably, parents, when we talk about external and the stoma bag, they say no. And external also you can have varices developing in the stoma, and they can bleed quite extensively from that stoma. But parents sort of do not take the option in our center. I don't know, others can tell about their experience.
PFIC2?
PFIC2, even PFIC2, we have done diversion. It has helped. I think just we need to buy time to postpone, as we know that PFIC2 can develop antibodies and the liver can, they need to go for a retransplantation, and always it's better to live with your own liver. Try to postpone, if at all possible, the transplantation.
So we should not, do we have Dr. Rohit here?
Rohit says he's joined, but
I can see his name.
Okay, so I think we need to take a decision at 7:30.
That's what.
It's 8 o'clock.
8:05, yeah.
So this session is still?
But let's go to Anshu because the message I mean.
No, but then that means that we actually end this session and we allow the next session to happen. Okay, so I must thank everybody, including the chairpersons, for being so good, and Dr. Naresh for having taken such a good, with very, very clear key messages here. And now we shift over to the next session because we still do not see any signs of Dr. Rohit being around, but once he's here, we'll take it.
Dr. Alam, I'm here.
Okay, you're here. So that's so nice to
Yes.
see your name here. So
I'm so sorry. But
now over to Dr. John for the introduction of Dr. Rohit Kohli.
I think we won't waste any time. I think Rohit needs no introduction. Rohit is the head of pediatric gastroenterology at the Children's Hospital in Los Angeles, and he's going to be highlighting on reliable biomarkers of steatosis and fibrosis and NAFL. Rohit, you can start, Rohit.
Hi, good morning, everyone. I'm so sorry for any delay on my end. I hope you can see my screen.
Yes.
I think you need to get your slides in. Correct. You can start.
Perfect. So speaking of biomarkers for steatosis and fibrosis, just a brief slide for my disclosures so that people know that I work with certain companies in this area. But more importantly, the incidence of fatty liver disease has been on top of mind for all of us in pediatrics for the last 2 decades. But if you look at the massive increase, this is explained by data from a very nice cohort that exists in a closed health system where all children are followed consistently throughout growth period called Kaiser Permanente in California. This system allows us to track their data in the same way for each child over the past 10 years. And they have shown an increase from 36 per 100,000 incidence of NAFLD to 58 per 100,000 over 2009 to 2018. That is a pure set of data which tells us without any argument possible that NAFL definitely in this region of the world is rising. And if you can extrapolate that to the rest of the world because of obesity rates rising, it is scary. So those two numbers, 36 to 58, please keep that in. That is why these conditions are now being treated even with bariatric surgery. And we know that that is an extreme intervention for children to have to undergo a permanent surgical procedure to lose part of your stomach or intestine to battle fatty liver disease or other causes of disease coming from obesity is scary, but that is definitely something that is happening. So that's one scary component, the rise and the attempt at intervening with fatty liver disease. But even worse is when these children become young adults and they start having liver transplantation. So this is the backdrop, this is the scenario wherein biomarkers are necessary, wherein we have to try to find out what we can do before we end up with children getting liver transplantation as young adults or even as adolescents getting bariatric surgery. So what is a disease? When we say NAFLD is a disease, it is that you have improper functioning of the liver. I'm sorry, there's a background something coming through. Improper functioning of the liver. So to be able to figure out whether a body or structure is being harmed is what our goal is before the body or structure is harmed. So before we get to significant disease requiring transplantation or surgical intervention, or even when we will have approved medication soon, we need to be able to discern whether you are diseased or you're living with fat in your liver alone. So in our clinic, this is our algorithm currently what we are following, where we take children referred to us from a primary medical physician or a practitioner greater than 9 years of age. And this is in line with the North American Society guidelines. And their body mass index for their age and sex is above the 85th percentile. In addition, if we see that their liver enzyme, specifically what we use just as a guidepost is alanine aminotransferase, is greater than twice the upper limit of normal, being 45. Of course, this goes back to ALT normal levels being defined by the safety and the Canadian caliper data sets being 22 and 24 for male and female respectively for adolescents. Therefore, we merged those two and said upper limit of twice upper limit is 45 around. At the first visit, we are looking at screening labs, primary non-obesity related liver disease rule out, and an abdominal ultrasound to rule out gallbladder or any other tumorigenic or biliary complication, not to diagnose fatty liver, but to rule out other problems. And of course, education of lifestyle. In 3 months, if the ALT has not normalized, then we are thinking about doing these biomarkers, which I will go over next. So what are these biomarkers? This is a little bit of a disservice to the word advanced, I will say, because MR elastography is now very established in terms of its efficacy. The issue is whether it is available or not everywhere. I know that tertiary centers across the globe, including in India, have MR elastography, but I think it is probably not as easily available as, say, an ultrasound. However, being able to define specific regions within the liver which have greater inflammation and or stiffness, MR elastography does a great job. Of course, these images here show regions of interest being outlined, and below here in the left bottom, you can see if you have discrete yellow-red regions, which are at the top of this scale, versus having purple or blue regions, which are at the bottom of the scale, you have either less stiffness, as in the top example, or greater stiffness, as in the bottom example. We have done a study previously, about 10 years old now, where showed that 2.7 kilopascals and above on an average for these regions of interest is signal stiffness. And that was a small study based on 35 patients, but this has been replicated by other cohorts since, an area of curve under the curve is pretty nice. The other one, which is slightly more patient friendly, I would say, in point of care and more accessible, if you have the interest in terms of the institution, is FibroScan. Now, EchoSense is the one that makes this. I'm not advising them or consulting with them. This is just an example, wherein again you can get a slightly decreased sensitivity and specificity compared to MR elastography. However, this is better performed in terms of accessibility. There are limitations, the most important being that if your child is above 30 body mass index, which certainly can be the case in fatty liver disease, you end up with less sensitivity. Especially with the KPA values, we have to be also careful for, especially for VCTE, which is transient elastography, that you are fasting at least for 2 hours or more. We talked about central obesity being a limitation. So you've done this workup up to now, you've got the imaging, but what happens next if we are still failing? I think even though we're talking about biomarkers, we cannot forget what is the gold standard, and which is biopsy. So the pros and cons of biopsy, for us, if you have been unsuccessful in weight loss, we have looked at these non-invasive biomarkers, and you continue to have obesity and elevated liver enzymes, we would say the pros are that you will be able to define NASH progression, and you will be able to be aggressive in your selection of patients in terms of who you would be spending more time with and or giving more attention to for prevention of NASH fibrosis or progression at least. Lastly, of course, there is a minority, a small minority of patients who you will pick up where there are other liver diseases previously undiagnosed. We all as pediatricians understand that invasive procedures in children should be the last resort, especially when such procedures like liver biopsy include risk of death. So at the end of this, if there is a refusal or the liver biopsy, we will have to discuss this continuously. We do use a liver biopsy if NASH is confirmed to be started on at least for 2 years based on the TONIC trial, which was published now in 2010 in the Journal of American Medical Association, JAMA, at 400 units twice a day. Last but not least, this is a pie in the sky, our hope for the future, which is liquid biopsies, wherein we are able to, such as for rejection, similarly for fatty liver disease, define fibrosis and inflammation based on site-off studies, wherein you are taking either sections from previously designated specific antibodies to these fibrotic genes and doing multi-dimensional or single-cell phenotyping and defining the difference between normal liver and, this is an example, chronic rejection, but also you can do the same technology for fatty liver disease. Thank you so much.
Thank you, Rohit. I think we have 2 questions. And so are there any questions in the chat box?
I would request that the questions that they are in the chat box can be replied by Rohit. All of you all please put it in the chat box because we took too long a time and 9 p.m. is valedictory and we have some more talks to go and we'll do the discussion in the end. In the meantime, I would request the second session chairs to please take their positions and all the questions that they are there, please put in the chat box. Rohit, can you kindly reply the questions in the chat box too and we'll address in the end. So for the second session, we have the chairpersons, Dr. C. Malam. Would you want to introduce them? Dr. Yacha?
Yes, yes, please.
So you are there. We have you. We have Dr. There were three of them. I'm just trying to. Satna Lal is also here. I could see her. And Dr. Ujjal Podar, I think I've seen him also join.
I'm sorry, I was speaking while I was mute. Ujjal Podar and Sadhna Lal.
And Dr. Ujjal Podar is from SGPGI. Dr. Yacha is ex-SGPGI and is now with Bangalore. So, Dr. Yacha, please introduce Anshu.
Dr. Anshu is professor of pediatric gastroenterology at Sanjay Gandhi PGI Lucknow. She has done her MD Pediatrics and DM Gastroenterology. She has done fellowship from Australia and also from Canada. And she has several areas of interest, particularly the liver diseases related to autoimmune, portal hypertension, and she has interest in inflammatory bowel disease. She has 135 publications in PubMed and 15 book chapters. She is the section editor of Gastroenterology in the Journal of Pediatrics. She's a brilliant mind, in my own opinion, because I have been working with her for a long time. And she'll be talking on, is there enough evidence to add sodium and renal functions to PELD, Bell score? So Dr. Anshu, please.
Thank you, sir. I think it's my privilege to be introduced by you, who's my teacher. So, and I really want to thank INASL, Seema and Neelam for giving me this opportunity. And I would like to share my screen. Is it visible?
Not as, oh yes, now, yes.
Is it visible now?
Yes.
Okay. So the topic given to me is that, is there enough evidence to add sodium and renal function to BELT? And as we all know that liver transplantation is a very successful modality of treatment with expanding indications. And the alternatives for such a good outcome are very limited. So there's a constant demand and supply problem which is going on. Especially this is in regards to the DDLT program. And therefore there's a need of a very fair and objective system of allocation, which is based on the disease severity and which treats children and adults alike so that the mortality while on the wait list is minimized. So with this in mind, the PEL score was developed in 2002. And as we all know, it is based on bilirubin, INR, albumin with additional points for growth and for age less than 1 year of age. And this was improvised above the child score, which was subjective in terms of ascites and other things. These were objective criteria. But very soon as 2005, it was found that in the Mount Sinai, this was a report published by Dr. Schneider, that the actual PEL did not lead to timely allocation of the liver. And only 10% of the candidates that were transplanted could be transplanted by the PELT. Rest all needs additional points, and it has been seen that continuously there's an increasing use of non-standard exemption points, which are subjective and variable across the regions, and nearly half of the children being listed are using non-standard PELT points. There's been increased waitlist mortality in those who are denied these non-standard points, and the number of pediatric transplants, especially in US, has remained almost the same while the adult numbers have increased. So there's a growing feeling that this PELT is not doing justice to the children in terms of liver allocation. And recently in 2018, this was a very good study where they calculated the observed mortality of the children, 90 days mortality while they were being waitlisted, versus the mortality which was calculated by the PELT score. And as you can see that the PELT score was underestimating the waitlist mortality by as much as 17%. And this was applicable across all disease groups, whether it was autoimmune, whether it was biliary atresia, metabolic, or other chronic liver diseases. So the PELT could accurately classify that, okay, this child is sicker, this child is less sicker, but it was underestimating the mortality. So it's not good. We are disadvantaging our children on the wait list because they are being underscored in terms of the risk of death. So going on, what can we do better to improve this PELT score? As we all know that hyponatremia is a feature of advanced end-stage liver disease, and this occurs because of splanchnic arterial vasodilation. There is activation of the renin-angiotensin sympathetic nervous system, and there is increased secretion of ADH, and therefore there is sodium and water reabsorption, and there is hypervolemic hyponatremia. In major of the cases of liver disease that we see who have hyponatremia, this occurs in association with an impaired renal function and usually moderate to severe ascites. Various adult studies and some pediatric studies have shown that hyponatremia is associated with a higher frequency of various other complications related to end-stage liver disease like HE, SBP, and HRS, and it is a marker of increased mortality. Keeping this in mind, there are multiple adult studies where they have shown that addition of sodium to MELT. The MELT score is a system of scoring which is used for adults and for children who are above 12 years of age. And it is based on bilirubin, creatinine, and INR. And multiple adult studies have shown that if you add sodium to MELT, you are able to improve the prognostication. In fact, the study which was published by Kim in NEJM showed that there was a 7% decrease in the waitlist mortality by using the MELT sodium rather than MELT. Therefore, the MELT sodium was uniformly accepted in 2016. Similarly, in UK, they use a score of UK end-stage liver disease, which also has sodium in the prognostic system. The PELT and MELT should have a similar prediction. The children and adults should be put on a similar footing. So the PELT has remained the same from 2002, whereas the MELT has been changed, therefore, and because of the various other reasons that I told you that it is underestimating the mortality, there is a need for modification of the PELT score. So let's look at the evidence what has been published in the pediatric literature. This is as early as 2010. This is a study of cirrhotic children listed for transplant. And as you can see that those who had a sodium less than 130, they had a much higher mortality as compared to the patients who had a normal sodium. Taking this a little further, this was a study from Brazil in 522 children with cirrhosis. And again, as you can see, that patients who had a serum sodium of less than 130, this is the graph for them, and those who had ascites in comparison to those who did not have ascites, they had a poorer outcome. Saying that the younger children, INR and bilirubin, which are already there in the PELT score, ascites and sodium, were predictors of outcome, poor outcome on multivariate analysis. Now this year in 2021, we have two very relevant important studies. One is published by Su et al., where they have, this is based on the UNAS database, and what they have shown is that they found in a large group of patients of nearly 5,000 who were listed, half of them were biliary atresia and half were younger than 1 year. They found that age, albumin, bilirubin, INR, growth failure, which are all there in the PELT, along with creatinine and sodium, were significant predictors of the waitlist mortality. So they devised a new score, which was the new PELT sodium creatinine score. And what they showed was that the area under the curve of this revised PELT score was much better, and it could correctly identify and prevent about 6% more, the 6% of more of patients who died because of the listing they could not get there. These patients could be correctly identified. And there was a difference of about 10 points between the actual PELT, the original PELT, and this advanced PELT sodium creatinine score. And as you can see from this slide, that this is the PELT sodium creatinine, this is the original PELT. So if you look at patients who had a score of less than 10 original, most of the patients had a higher PELT sodium score. And this difference on an average was about 10. So if the original PELT was 10, the average newer PELT sodium creatinine would be somewhere around 19 to 20. This was another large study where they had children who were listed for transplant. And the glaring point was that from 2002 to 18, the use of non-standard exemption points increased from 20% to 60%. So with the original PELT, they could not be listed. So people were using exemption points so that they could be listed. And here, what they found was that 18% of the patients had a hyponatremia, and renal dysfunction, which was defined by the GFR, was present mild in 15% and moderate to severe in 5%. This graph very clearly shows that as the GFR reduces, for each cutoff values of the PELT, the probability of death increases as the GFR surges. Similarly, this was a trip of sodium at somewhere around 137. With a lower sodium, the risk of death was higher, and with a higher sodium also, which was extremely uncommon, but the risk of death was increasing. So in patients who had mild or moderate renal failure, the risk of death was much higher than those who did not have renal failure. And similar was the case in patients who had hyponatremia or hypernatremia in comparison to those who had normal sodium. So they calculated, basically, they had three models. One was the original PELT, then they had PELT plus sodium. The other was PELT plus the renal function, eGFR. And the third was PELT plus sodium plus the eGFR, which they labeled as PELT plus. And this PELT plus had the maximum area under the curve. And this, using this PELT plus, we could avoid the around 6.5% of deaths while on the waiting list. The question which was raised was that, is it safe or is it advisable to do a liver transplant in patients who had moderate to severe renal dysfunction? Are they likely to have a poorer post-transplant outcome? And are we doing justice by using these organs for them? So what they showed was that without transplant, these patients with moderate to severe renal dysfunction had only a 30% 1-year survival. But with a liver transplant, this was 92%, which was very good. And in this group, there was a mild reduction in the post-transplant outcome, but that was only in the first 30 days, and later on the outcome was very good. So they concluded that the listing eGFR or need of dialysis and serum sodium were potent independent predictors of 90-day death in pediatric transplant candidates, and this captured a risk which was not accounted by the PELT score. So let us look at what is the scenario in ACLF, which is again a very highly select group of cirrhotic patients who have a very poor outcome. So this is an adult study which has again characteristically shown that hyponatremia is twice as common in ACLF patients as compared to no ACLF, and it increases the risk of death by 7 times in those patients who have hyponatremia, again thereby suggesting that it is a very poor prognostic marker. This is our study where we looked at 110 DCLD patients. Half of them had more than 2 organ failure, so you may say that they may qualify for the ACLF, but we did not divide them into ACLF or non-ACLF. And what I would like to say here that serum sodium and organ failure, which included the renal failure, were the predictors of outcome on multivariate analysis, again showing that the sodium levels and the renal functions are important parameters which determine the outcome even in pediatric DCLT. This is another study which has been published from the ILBS group, and this is all ACLF children, and they also have shown a similar finding that the scores which are based on organ failure, that is the Cliff SOFA and the ARC-ACLF score, were best in predicting the outcome in this high-risk group as compared to PELT. And again, highlighting the importance of acute kidney injury, they have very clearly shown that if a child with ACLF has AKI, the risk of death is 7.7 times higher than a child who does not have acute kidney injury. There are large studies in adults which have been published very recently in last 2 years, which have involved nearly 1 lakh adults. And what they have shown is that when patients with ACLF, the grade of ACLF, that is the number of organ failure, is a much better predictor than the MELD sodium score in patients with multi-organ failure. But mind you, there is a very tight window of opportunity, and you can see here that the time between listing and transplant in these patients with ACLF3 was only 4 to 5 days. Therefore, there is an urgent need to define scores which are more applicable for ACLF, and it might be a combination of an ACLF grade and a MELD parameters which might be working the best. So this ACLF is a separate group, and this is a study which has been reported from US, where they have shown that pediatric ACLF accounted for about 2.5% of all the total listings, and it had a higher mortality, even higher than ALF. But this poor outcome was maximum within the first 90 days. Thereafter, the outcome was good. So this graph shows that very clearly that there is always a window of opportunity where you can list these ACLF patients and get away with a good transplant. Otherwise, they might become so sick that they might need delisting from the transplant and they would not be suitable for transplant. So the challenges which are still pending for allocation decisions are, what should be the timing and when should we be delisting a very sick patient of ACLF for transplant? So what are the concerns? Having seen that sodium and creatinine are good, they are improving our prognostication. So are there any concerns with adding these two parameters to the PELT score? The most important concern is that sodium is a very fragile parameter, and simple things like diuretic use, a large volume paracentesis with albumin, administration of hypotonic fluids can change the sodium levels very fast. We have to be extremely careful while we are transplanting patients with hyponatremia, because issues like a longer hospital stay, neurological complications, and if this hyponatremia is corrected very rapidly, then the risk of developing an osmotic demyelination syndrome is there, which can be associated with a poor prognosis. Similarly, there are very few data on acute kidney injury and liver disease children. What should be the standard definition? What is the prevalence? Children have low muscle mass. Therefore, there are issues with estimation of GFR with creatinine-based calculations. Second, a lot of liver disease in children, patients may have an intrinsic renal involvement like allergies, tyrosinemia. So are we justified in using a creatinine-based score in these patients? Similarly, there's a study from King's College recently in 2021 where they have said that biliary atresia patients are having more of portal hypertension and cholangitis problem and not the sodium and creatinine. So this score might not be very applicable to this. So do we need disease-specific scoring systems in children? And as I've shown already, that ACLF is a separate group where the organ failure scores are much better rather than the other scores. So in the meanwhile that we are working on these deficiencies, what are the other options to improve this demand-supply therapy? As per the Declaration of Geneva, the mankind owes to the child the best it has to give. So we have to use all efforts to improve this gap between demand and supply. And this we can do by utilizing livers from pediatric donors only for pediatric recipients. We can increase the use of split liver transplants. We can increase the extended donor criteria to expand a donor pool. Obviously, living donor liver transplant is the best option for the utilizing this. And obviously, we need to work on the other policies for the loco-regional distribution. The second thing which I would like to stress here is that simultaneously, while we are working to improve the PELT with sodium and creatinine, there is another thing which is known as growth failure gaps in the PELT score. As we all know that the growth failure is given points in PELT scoring, but this study, very interesting study from Swenson has shown that nearly about 17% children, they have Z-score which is less than -2, but still they do not get the criteria points and they lose 6 to 7 points. Therefore, they might actually be scoring lesser PELT points and may not qualify for listing. And secondly, there are lots of weight fluctuation, which is common in CLD patients with ascites, which may again not do justice if you are doing the weight while with the patients who have got, most of these patients would have ascites. Therefore, the suggestion is to modify these growth failure points, use them as a continuous variable rather than giving them as growth failure present or absent, because they lose on 6 to 7 points, or use other methods like skin fold measurements or measures for sarcopenia to qualify growth failure. So to conclude, I would like to say that PELT definitely underestimates the waitlist mortality in children, and it needs to be modified. There is absolutely no doubt about this. Addition of sodium and creatinine adds to the accuracy of PELT for transplant prioritization. It has got, once we add sodium and creatinine, the accuracy improves, and this helps to identify more of the at-risk patients, and it reduces our reliance on the non-standard exemption points, because the use of these non-standard exemption points are subjective and variable across center to center, so they introduce bias. However, there are certain limitations which we need to work on, and more data is required. I would like to stress that ACLF is a separate group for which this PELT sodium creat may not be the best. A scoring system based on organ failures may work better, and we need more data on that. Children have a diverse etiology of CLD, so we need to consider whether there is a need for an etiology specific score, especially in those who have renal dysfunction, certain etiologies where there's more of portal hypertension. The other measures for increasing the donor availability need to be utilized simultaneously while we are working on this, and growth failure gap in PELT score should be addressed with urgency to improve the outcome in this vulnerable group of especially those children who are less than 2 or 1 year of age. With this, I would like to thank you very much.
Thank you, Dr. Anshu, for your brilliant lecture, which was based on the literature, published literature, your own work, and very clear that there's a need for disease-specific actually scoring system in pediatrics because of varied etiology, which is very right. And I thank you very much for your excellent and brilliant presentation.
Thank you, sir.
Go to the next chairperson.
Dr. Ujjwal, would you like to introduce Dr. Bikrant?
Yeah, Neelam, I think we need to have some more questions on this. This is a very...
To put all the questions in the end, you have to be fair. The others are prepared. The end discussion can go on for an hour. But all those who have taken their times, so Bikrant will get it. If you see chat box, you're not seeing chat box. Dr. Rohit has replied to at least 12 questions in the chat box. Please see that. All the answers are being, I'll request everybody to put in the chat box, and once the talks are over, we can sit for another half an hour. Dr. Ujjwal Podar, are you there? Dr. Podar?
You have to unmute yourself.
Audible or not?
Yes, yes.
Yes, thanks, Neelam. The next talk will be delivered by Dr. Vikrant Viharilal. He is Associate Professor in the Department of Pediatric Hepatology at ILBS New Delhi. And he is going to speak about chronic hepatitis B in children, home to treat in the year 2021. Vikrant, please start your talk.
Thank you, sir. I hope my slides are visible to everyone and I am audible.
Yes, just do this PPT mode. They are in a slide mode.
Yeah, thank you. So good evening, everyone. So in the next 10 minutes, I have to speak to you.
You are not audible, Vikrant.
Vikrant.
Chronic hepatitis B had come way back in 2013, and since then there has been no further modification.
Vikrant, some audio problem from your side.
Vikrant, are you in the hospital? We can't hear you.
I wish the
Let
wife.
me call him up.
Till you arrange that, there is only now.
Am I audible?
Yes, you are.
Yeah, thank you. Okay, so this guy.
Your personal video that will take less Wi-Fi. So don't put your video, just show the screen.
Let's all stop our videos except the chairpersons.
Yeah. Okay.
Go ahead, Vikrant.
Yeah. Yeah.
Ujjwal, unmute yourself and tell him, please.
You are not audible. There's something wrong with you.
Yeah, I think he's sitting in an area.
You're using a broadband, not a hotspot.
If you have any problems, you can come to my room. You can speak from here. If you're in the hospital, I'm not sure if he's there in the hospital.
And in the meantime, since we have only
let me call him.
20 minutes, we'll take some discussion, or we proceed with the next talk. That is 10 minutes. I'll wind up so that he gets 10 minutes. We have just 20 minutes to go.
Nilam, I think you go to the last talk and he can come back after fixing his problem.
I think that will be better because we need to.
Yeah, wind up by 9 o'clock.
Yes.
So please go ahead with the, I think you can ask Vikrant, you can correct yourself and come back.
Okay, Vikrant is trying to connect with his phone. He's not here in the hospital. Otherwise, he could have come to my room. But then we'll just, if you want, you can ask questions to Anshu from the chat box. Sadhna, you want to take them up because Sadhna, you're the last chairperson. Take them up.
I think there are a few questions. Specifically, I could see that somebody has asked about the role of midodrine in end-stage liver disease and severe hyponatremia. Anshu, would you like to answer that? And there's another question on the peak creatinine being used as a marker.
I would not have any personal experience of using midodrine as a hyponatremia, but the adult literature, there is a suggestion which is there that it can be used. The second question, I didn't get it, Sadhna.
He's asked whether they should should the peak creatinine be used in HRS for children in calculating the prognostic score going for liver transplantation, as they are at high risk for AKI post-LT, as is being suggested for adults.
Yeah, the literature is extremely limited, and what they have used, the data that I presented was of the creatinine, which was at the time of listing. So obviously, whatever was the peak creatinine at that point of time, that is what they have used.
Okay.
Okay. There's just one more thing. I think what Piyush is trying to ask, I feel that from the point of view of children, it is the lower creatinine which is causing a problem because of various reasons within in a decompensating CLD patient. We know that their creatinine doesn't rise. So Anshu, do you feel that a cystatin C may a cystatin C based calculation may help out better with these children?
See, Seema, these are very early days. Like, we have hardly one study which has come out which is saying that cystatin C might be better than creatinine based. And that's what I said, that there is no we need to work on standardization of the criteria for saying AKI. And this data, even on cystatin C, is just very, very limited to say that yes, everybody should be using, because there are issues with availability of cystatin C at all centers, the cost and other things. So boiling down to the availability, maybe create based things might be better, but then how much rise, how frequently it should be done, all these issues needs to be fine-tuned, because we hardly have any data. Both these studies which have come are only of 2021. So we need to have more data to say that what I would recommend for that. Definitely cystatin C based was found to be superior in the study which was published. I think it's from your center only, where they have very clearly shown that cystatin C based calculation of the GFR was better than the creatinine based calculation.
And most liver centers, even Neelam would say that most liver centers now are using cystatin C post LT at least on immunosuppressives. So that is the experience that we are speaking from, basically.
Yeah, but for the listing, whether we should be the topic which said that whether we have to include creatinine and sodium, those would be the pre-transplant listing.
I agree.
Yeah.
Maybe a fold increase in the creatinine would have to be worked out, and that would be a more practical way to do these things, because the newer markers are not validated as yet. So possibly the rate at which your creatinine is rising from the baseline would be a very important.
Yeah, I think the maybe the KidGo criteria is what people are using most often. But again, as I said, the studies on AKI in pediatric CLD is extremely limited.
And another question to you, Anshu, like we are in a country where live like listing is, we are into live related transplantation. So maybe, you know, these discussions on the addition of creatinine, and they are relevant, but to a lesser extent.
Yeah, definitely not for our country that much.
What do you think that is it possible to use the modified PCLIF as you do for ACLF for patients with chronic chronic liver disease as listing for?
See, that's what I'm saying, that definitely for ACLF, we have the adult literature as well as the pediatric literature suggests that organ failure scores are better. For the decompensated chronic liver disease itself, what we have shown in our study was that the pediatric CLIF so far was the best score. But again, that's only a single study and it needs to be validated further before I can say that.
Okay, you know, Dr. Pudar, would you like to ask Vikrant if he's there and restart, or else we can go on to the next?
Vikrant, are you there? Are you ready with your presentation?
Yes, sir, I am ready. I changed the laptop now.
So can we, Neelam, can we have Vikrant's presentation first? Can you, Neelam?
Yeah, I've done it.
Okay, now Vikrant, start.
Yes, sir. Yes, sir. So is my screen visible?
Yes.
Yeah. So
yes.
the current guidelines of SFEGAN suggest that all children with persistently elevated ALT, irrespective of their HbEAg status, should undergo a liver biopsy, and only those with advanced fibrosis should undergo treatment first with interferon, and if that fails, then with the oral antivirals. Now, the few points that I would like to discuss on this as I go through my talk would be, first, whether the children in immunotolerant phase, so-called immunotolerant phase, deserve treatment. What is an elevated ALT? Do children with F1 and F2 fibrosis need treatment? Are they at risk of SCC and end-stage liver disease? Is interferon alpha monotherapy the first line of treatment? And obviously, we know the fallacies with lamivudine. So coming to the first part, do immunotolerant children need treatment? Now, this was the practice till, it's the practice right now also. This is based on multiple studies which have shown that if the ALT is persistently normal and HBV DNA is very high, more than 10 to the power 8, that is seen in immunotolerant children, these children are at very low risk of developing long-term complications like HCC or end-stage liver disease. However, things have changed over the last 5 to 6 years, and there are a couple of papers which have changed the thinking. And this one by Patrick Kennedy and Bertoletti has shown that children and young adults in immunotolerant phase have as many HBV specific T cells as those in other phase. And these HBV specific T cells can produce an equal amount of Th1 cytokines. But what is different is in this phase, the HBV specific T cells are not able to recruit the inflammatory cells like monocytes or these granulocytes. And hence this phase has also been labeled by them as a high replicative but low inflammatory phase. Moreover, it has been shown that HBV DNA integration and clonal hepatocyte expansion is similar in immunotolerant phase as compared to the other phases of chronic hepatitis B. That means the risk of SCC is real. And this landmark paper by Kim et al. In Gut 2017 changed the practice. They showed that these are adult, this is adult study. So they showed that adults in immunotolerant phase who are untreated have higher risk of HCC as well as higher risk of going to end-stage liver disease requiring death, requiring transplantation or dying, as compared to treated patients in immunoactive phase. So one thing is definitely clear, and it is also seen that HBeAg positive and high DNA is a risk factor for SCC as per REVEAL HBV study. So this is definitely clear that immunotolerant patients, young adults, adolescents are at risk of SCC and risk of end-stage liver disease, even in immunotolerant phase. But the question is, do we have armamentarium to treat them? There was some hope when the first two studies were published, and they showed that not very good, but yet 20 to 40% of patients may achieve HBe seroconversion and 17 to 20% may achieve HBsAg clearance with a combination therapy of interferon-based combination therapy. However, these results have not been replicated in recent studies. This is a study from our center where we took children with ALT up to 60 and we did not find HBe or HBs seroconversion in any. And these two are multi-centric studies. This is from the Hepatitis B Research Network from United States, and this study is from multi-centric European study. And both of them, only one children in each group, each of these studies achieved HBe and HBs seroclearance with the combination therapy. So much so that this trial by Varghani et al., this is a randomized controlled trial, had to be stopped midway due to the futility of treatment. So yes, HB immunotolerant children need treatment, but as of now, we do not have drugs to treat them. And we can also see that the rates of HBe and HBs clearance that we are achieving with the combination therapy is comparable to the spontaneous rates of HBs clearance, that is 1% per year, and 6% HBeAg seroconversion that we see in untreated children. So we are not offering any additional benefit by treating them. Second question is, what is an elevated ALT and when should we treat the children? Now, this is a brilliant study from the multicentric United States group. They showed that when they use the site-specific upper limit of normal for ALT, that is mostly 40 in most of the centers, around 39% children could be labeled as immune active. They would qualify for treatment. However, if they use updated upper limit of normal, that is coming from the safety study, where it is 25 for boys and 22 for girls, as many as 62% can be labeled as immunoactive and will deserve treatment, will require treatment. But does decreasing the ALT cutoff and labeling more children as immunoactive phase has any therapeutic or prognostic implications? I would say no, because what we have shown from our study on HBeAg positive children, that an ALT baseline more than 100 predicted chances of HBe seroconversion with 100% specificity and close to 90% specificity, 100% sensitivity and close to 90% specificity. Similarly, the multicentric hepatitis B research network study showed that all the children with ALT less than 60 failed to achieve HBe seroconversion with sequential therapy. So whether you bring down the cutoff of ALT, it is not going to help, as anything below 60 or maybe even below 100, they are not going to respond to at least the currently available therapies. The third part, what should be the treatment of choice? Should we start with interferon monotherapy? Should we start with antivirals? Or should we start with a combination? So in children, there are not many studies to compare one group with other. What was seen in our study, now this is the subset of our study where I'm including the children only with ALT levels more than 60. And what we have shown that PEG interferon plus nucleoside analog combination therapy is superior to nucleoside analog monotherapy in whether it is HBe seroconversion or virological clearance or HBs seroconversion. Whether you use PEG interferon alpha 2A or alpha 2B, the response is same, and the same results have been replicated in adult studies. So the best treatment is if you combine nucleoside analog with PEG interferon. Sequential is theoretically better than simultaneous, but this has not been found in studies. Now, which antiviral to use? Should we use lamivudine, tenofovir, or entecavir? Jonas et al. Have shown that entecavir is safe in children up to 2 years of age, and the cumulative entecavir resistance was seen in only 2.6% at 2 years. So yes, entecavir can be used in children beyond 2 years of age. Tenofovir has been shown to be safe in children between 12 to 18 years of age, and I am sure we are going to very soon get results in children younger than 12 years of age. The best advantage with tenofovir is no antiviral resistance was seen at 3 years of follow-up, and hence it may be superior to entecavir in that respect. Lamivudine, obviously, we have stopped using apart from children less than 2 years because it has very high rates of antiviral resistance. Now, there is one study in Journal of Hepatology which has some remarkable results, I would say, but which shows that when antiviral therapy with lamivudine was started in infancy by around 6 months of age, 83% of children achieved HbS seroconversion by 12 months. That is a huge number, unheard of in pediatric hepatitis B therapeutics till date. In the second group, they started interferon at 1 year of age, and even in that group, they achieved reasonably good number, that is 36% losing HbS-Ag by 12 months. Now, there are some things that are not clear from this study. One, what was the denominator? They treated 29 children, but what was the denominator, and what percentage of children can receive treatment at this young age? Definitely they had very high ALT. Was this flare happening? Does flare happen so early in the course of hepatitis B before the child goes into that immune tolerant phase? That is not known. The second thing that makes us think about the results is more than 70% of these children had received immunoprophylaxis with hepatitis B immunoglobulin. So whether this HbS loss was the result of this hepatitis B immunoglobulin and was a natural course, that we don't know. So I'd best leave it to the judgment of the audience. Now that brings us to the next question. Once we start the antivirals, now most of the children will not lose HbS-Ag. So we cannot go on with treatment for, like, say 40, 50, 60 years. There will be risk of antiviral resistance. There will be cumulative risk of adverse effects. So how to stop the antivirals? So this is a thesis from one of the students at ILBS, yet unpublished. It just so in this we have shown that if the child has achieved HbS seroconversion, there is absolutely no risk of relapse and we can stop the treatment. In absence of HbS seroconversion, at least the child should achieve HbE seroconversion. If the child is HbE-Ag negative at the time of stopping treatment, only 1/6 have virological relapse at 12 to 18 months of follow-up. Whereas if you stop treatment when the child is HbE-Ag positive, almost 70% have virological relapse within 12 to 18 months. So if I have to give a flow chart for treatment of chronic hepatitis B in children, I would say that children with normal ALT or up to 2 times elevation of ALT, irrespective of their HbE-Ag status, cannot be treated as of now. Definitely this group, HbE-Ag positive chronic infection, deserves the treatment, but the currently available therapies are ineffective in them. Now, if the ALT is persistently abnormal, if is HbE-Ag positive or negative, ideal way is going through liver biopsy to confirm that there is active inflammation. Regardless, most of these children will require treatment. The best line of treatment is sequential therapy. The best antivirals are currently tenofovir in more than 12 years and entecavir in less than 12 years. First give antivirals, then give combination therapy. PEG interferon can be given for a finite duration, and entecavir and tenofovir, whichever you are using, can be stopped after HbS seroconversion preferably, but definitely at least HbE seroconversion has to happen. Only after that you can stop the treatment. Thank you.
Thank you, Dr.
Sadhna.
Grant.
Sadhna,
Sorry.
please.
Can we have questions at the end, Ujjal? Otherwise, the third speaker will not get a chance to talk.
Okay.
No, it's okay. I think this is a very interesting topic. You can proceed, please.
Would you permit? Okay, then.
Just
Would you go?
Because anyway 9 o'clock that session is started. So those who are interested would have left for the valedictory.
Can I make
Please,
one
please.
comment?
Yes, please, Ujjwal, go ahead.
I think we'll not take more time. Vikrant, a nice presentation. You highlighted most of the facts, quoting the literature. Just I want to make a comment about this natural history of hepatitis B, and as a pediatric gastroenterologist, what is our role? We have our moral and social responsibility. Everybody knows chronic hepatitis B in children, they are healthy children. They don't have any disease. But we, as after 18 years, they'll go into the adult, they develop E-negative hepatitis, cirrhosis, HCC. So we cannot wash our hands saying that after 18 years, the adult responsible, let them treat. Now there are two facts we have to remember. The age of seroconversion is very important. That will dictate the subsequent course of the disease. The Taiwan study has clearly shown, Journal of Hepatology in 2016, that if a child does not get seroconverted before 18 years, his chance of developing E-negative hepatitis is double than those who are achieving seroconversion, whether spontaneously or treatment-wise. Second fact, you highlighted the Chinese study that this is called window of opportunity, that when we are starting the treatment, that probably will make some difference. If you start treatment early, like what the Chinese study has shown, in infancy, very high rate of HBC conversion. And that guy Bartoletti, who is a very famous immunopathologist, in the editorial of same issue of Journal of Hepatology, he commented that this is a window of opportunity. We should think about treating all children, irrespective of the ALT/AST status, to prevent the number of infected hepatocyte and probably integration, which you have highlighted that high risk of developing HCC. So what you said is clear, that is from the literature, but we need to think about it, that should we stop thinking of treating chronic hepatitis B in children, thinking that anyway, they are not going to develop any disease in 18 years as a pediatric. Vikrant, you can give a little bit of comment and then we can go on to the next talk.
Thank you, sir. Yes, sir, I agree with you that definitely a larger chunk of our children will need treatment. As far as this study goes, yes, it remains to be seen. We don't get children this young actually to us, and most of our centers.
Criticize that study. Forget about this study.
Yeah,
Just
yeah.
give the overall,
So,
because
but
already you
definitely
highlighted
one thing
everything.
is clear from this study, that a few of these children had very high ALT in infancy. So whether these children are, can we identify this subgroup of children who have very high ALT early in infancy, and can we treat them? Yes, this remains a question. And yes, the natural course, our understanding of the natural course has changed a lot. We know that HCC can occur. The natural course is not a linear progression. There are no tight compartments in hepatitis B now, like immunotolerant, immunoactive, and it is not a linear progression. The patient can go from one box to another box, bypassing the other things. So the dynamics is changing. We definitely need to treat a lot more, but then we have to see whether we have a better armamentarium. The current drugs, we are limited by that. But yes, we may have a window of opportunity if we can find these children, especially the infants with high ALT. We don't know what percentage of our infants with chronic hepatitis B will have this kind of high ALT, but that remains to be seen. And if we can treat them, yes, there is nothing like that.
Thank you, Vikrant. I think we are now, Sadhna, this is your.
Okay, so you've summed it up nicely. I just want to add one comment that don't forget the immunosuppressed children who are at high risk of activation. They need to be treated as well, irrespective of whether you have elevated enzymes or not. And the second thing is, it is not all that simple that you stop the treatment after the seroconversion for HPE has happened, because HPE seroconversion practically never happens without interferon, and even with interferon very rarely. So it is not all that simple. Invariably, there is going to be a relapse, and possibly there we might be helped by the newer markers which are coming up, like pre-genomic RNA and the hepatitis B core antigen, which could probably help to predict whether we can actually stop the therapy in these patients.
One marker, ma'am, that we evaluated in this study when stopping antiviral was cccDNA in the liver tissue.
That's very difficult to do,
Vikrant,
Dr.
answer it in the chat group, please.
Okay, I think that will go on to the next talk. And sorry, Neelam, for taking up your time, but you can go ahead and nobody needs to.
Vikrant, stop sharing so that I can share.
Yeah, sure.
Is it showing?
No, not yet.
No, not showing as yet.
Yes, go ahead.
Yeah. So I would just like to comment that this COVID and liver disease, what's new and what have we learned? So when we started in 2020, at least in India, that was when we realized that the COVID we thought has significant morbidity and mortality in patients with liver disease when compared to general population. This was what we all said. And people with cirrhosis may be at increased risk, this was thought, and those who are liver transplanted, because of the immunosuppression, there could be much problem. But before we understand what the effects are going to be, just this one important slide. How does the liver get affected? One is we know that the ACE receptors are directly on the cholangiocytes also. So there is a direct involvement of the liver. Then there is an ischemic effect that can happen. Then the drugs that they have been using, and I'll show a slide how the drugs are said to be, and the cytotoxic effect of the virus itself on the liver. These were the major points, besides an underlying liver issue, which is a fatty liver, scarring, etc. So this is what the cytokine storm, which we talk about, that is also an important part which affects the liver, because through that, the CD14, 18 cells that we've been talking, and when you look at the liver biopsy, the various studies have shown that you could find either the steatosis secondary or lobular inflammation, portal activity, degeneration, necrosis, and infiltration by lymphocytes, monocytes, neutrophil, etc. Besides that, later on the studies also started showing that there's some additional mechanism, which is the dysbiosis, viral translocation, persistence in the enterocytes, the leaky gut production of toxins, and the liver mitochondrial dysfunction as a source of oxidant and production of ROS. So these all have been enumerated, and liver is said to be the second major organ after lung that was talked about. And the drugs that we were using, especially talking about azithromycin and the other moxilin, erythromycin, paracetamol, all these drugs were also as a culprit. So what really in the last 1.5 years we've learned is that the liver enzymes are showing mild to moderate increase, most of the time mild, but what is its significance? We don't know. It's not very clear, but these patients have shown, unlike dengue, we don't classify them into mild, moderate, severe based on the liver involvement. Ultrasound can be a useful modality in COVID-affected liver, where either it could be normal or it could show some typical acute hepatitis like presentation or the vascular complications that we can see. And there are studies to show that when the liver is severely affected, either we are talking about usually the hypoxic damage, and people have been talking about liver enzymes, GGT and ultrasound normal. MRCP also showed some irregularity of, then maybe is it the ischemic sclerosing cholangitis like an effect that was seen in these patients. Just like we've talked about these patients, Just like the lung, we've talked about the scarring which can have a long-term effect. These patients who had severe involvement because of hypoxia, the oxygenation going very low, can have long-term effects which we need to follow up and see. This is a beautiful summarization of the thoughts in adults. They two good papers. One is this 2021 Sareen, and one is from Narendra from our center in Medanta, where they've talked very clearly about what the effect have been on transplant patients and the apostle group. This slide summarizes it in adults, that if you have no liver disease, then just raised bilirubin and AST indicates severe disease and ICU stay. In children, I mentioned to you that mild increase was seen with no, we could not justify what it was. But adults, they say that increase with increased bilirubin, these are markers of ischemia and injury like dengue, and they need to be in ICU because that does suggest increased mortality in them. In non-cirrhotic chronic liver diseases, the comorbidities have an effect, and the severity of the disease is as high as 12% and mortality 6% in this cohort versus the general, which we say less than 1. So child age cirrhosis mortality from 6 has gone to 17%, and severity from 12 has gone to 20%. Child B and C cirrhosis, severity has gone from 11 to 33% and mortality to 41% in them. And the study which I said, the next one from the review which was done from the Medanta, along with the complete review of PubMed series of all papers, they showed that if you had it post liver transplant in the early phase, mortality was as high as 18.5. The next few minutes, what have we learned in pediatrics? This questionnaire, which was from Italy, on the 377 patients that were CLD, 369 responded. 26% of these CLDs were cirrhotic and short percent transplant. Majority of the patient maintained a good health status. Susceptibility to SARS-CoV-2 infection was similar in the patient regardless of the underlying CLD, despite a high incidence of the observed suspected cases, absence of, and they had a favorable outcome. So in pediatric patient, this paper concluded, which was a questionnaire, that they did not have any extra risk factors. A PubMed review, which was recently published, and Deirdre has also been one besides other authors from USA and Europe. This was a review where they said that the COVID-19 related liver injury presents with mild elevation of transaminases, though its clinical significance is unclear. Children with CLD, including autoimmune and post-liver transplant, did not have an increased risk of severe disease. But mind you, when these papers came, they did not have Delta variant. We've been talking about the earlier variant of Alpha and Beta that they talked about in the America and UK studies. Unlike the previous data in adults, lot came from Indian data, which had the Delta variant. So according to this study review, they summarized that you should provide a normal standard of care to these patients, and you should continue to give them immunosuppression to prevent relapse or remission, because these patients were either autoimmune or transplant. Be careful in that. Then there was this interesting paper about what COVID-19 and pediatric liver disease, because by then we have huge data in adults to show that obesity increased mortality because of its associated metabolic diabetes, sugar, etc. There was very high, we all have seen mortality in obesity. So is there an interplay? This paper talked about, and another paper also talking about the same, that this was the Chinese paper. They are talking that obesity increases the risk of severe COVID-19 in children, and metabolic associated fatty liver patients, the risk would be sixfold for them to get into severity. Having said that, we have several reports from all over that because of the school closure, right, in India, everywhere, Asia, we've been talking that there is increase in obesity. So pediatric liver experts are very worried that this increase in obesity might give rise to severity of COVID, which and this new Delta variant. So we have to be very careful about it. Even in India, 10% generally we say pediatric from the studies that we talk about the obesity, except from the rural area, most of the urban talk about that. And then in the transplant patients, the worry which we have that will they be immunosuppressed, at least the DAY-3's paper we're talking about, and this small series, and I'll share you my experience of 14 patients. This 18 centers, they talked about it, very small. They have said that there is a change in the practice. They moved to telemedicine like us. Only two patients, severe cases, majority could be treated by online consultation in OPD. So there have been a lot of papers in children. And so what we summarize as, they could be a new liver disease. You give them normal standard of care if there is a mild raise in symptoms. And those who have stable chronic liver disease, you continue online visits with them and use telemedicines and all. But those who are in advanced liver disease, definitely when they have COVID-related problem like we're talking about BC or transplant patient, it is better to keep them under your nose. And this is how the protocol suggests that you must, besides doing the LFT, you must keep them in ICU and look for the various markers, which we all do, as all of us know, in COVID-19. But this is the last slide, which I want to show. In the last 6 months, we had an experience of 112 COVID positive patients, and majority of them that came to our clinic were with the one who had GI manifestations. Theoretically, they say that maybe it is 10, 11% or 12. But our experience maybe was biased because we were a tertiary referral. Majority of the patients came with GI manifestations like diarrhea, pain, abdomen, vomiting, with an associated fever. But talking about liver disease, those who had chronic liver disease, 12 of them had COVID, and only one needed an ICU admission. Rest could be managed by OPD, telemedicine, and all survived. And in 13 post-liver transplant, we had this, and I used to follow the earlier protocol. I would stop their mycophenolate and I would continue with tacrolimus. And there, this is the last slide. Sadly, 2 patients from Bangladesh went into MISC, and their country, they could not salvage these patients. So thank you. Liver is the second organ after lung that we are worried about. Thank you.
Thank you, Neelam. That was interesting, especially the part about missing the post-transplant scenario. But I think we are short of time, and I don't see any questions in the chat box.
I think it's important topic, and since the last one, we have asked for 5 more
messages from the. Okay, go ahead.
Okay, so I have just one question, which I feel Neelam has really rightly pointed out, that there is a group of patients who are going to be in real trouble if we do have a third wave going in our country. And I do not know what is happening in US about that. And this is the group which possibly Dr. Rohit was talking about, is the NAFLD group, who already, Neelam, you would agree with me, who already we see quite often if they've had a comorbidity with HIV, infection or HEV infection. I mean, some of them also have HEV or one other infection. They come to you with really much more severe, pattern or severe disease than otherwise an HIV patient coming to you. So I think that those patients who come to us with more comorbidity or more complications with HIV are the ones who are having NAFLD in the background, and this possibly even COVID will have the similar effect.
I'm glad that's what I highlighted in the talk about the two important points. And I said this is a matter of great worry because with increasing obesity and metabolic, and there had been another paper which said that there was a 10% increase in the incidence of HbA1c deterioration in these patients during the COVID state, the obesity, just showing how there was worsening in the metabolic state and these patients have higher risk. So as I was highlighting that with this Delta variant and also, there is a matter of worry, we've been saying no. And as you rightly pointed, right now, I have a patient who actually had hepatitis A and also had mild pancreatitis with myeloid, which was known, and presented with Kawasaki-like syndrome, presented with jaundice and COVID antibody, but I was not giving steroids because I thought, but the echo suggested a dilated vessel and I had no other option but to give high dose steroid despite hepatitis A and jaundice in 1500. So these are the cases where you are absolutely worried how to go about it because she had HFNC requirement also. And so these two MISC patients, we've been lucky that we could save in India, but the treatment all over India is not uniform. You rightly note that MISC, even in USA and all, the mortality is to the tune of, close to 0.1 to 1%. And in India, with this care and MISC, I always get very worried that with the total population of 40% that we have in India who are children, and even if I take the data of the ICMR study which said that 57% patients were having antibody positive, of which less than 50 in the rural and around 55 something in the urban population, that still leaves us with 45% of the children.
I would ask you to please ask Rohit, or maybe Sadhna can do that. Rohit is writing a lot in the chat box.
Dr. Yata, meanwhile, wanted to make a comment.
No, please, ask Rohit, because NAFLD is something that we really need to know. And Rohit, can you give your few comments on this quickly, briefly?
I would never speak ahead of Dr. Yacha. Professor, sir, why don't you go ahead and then I can comment on that.
Don't do opportunity to people from their own country.
No, sir, it's just that NAFLD is something that I felt that we should be knowing more.
My
2 minutes, sir.
3 minutes with Dr. Sadala.
Please go ahead, sir.
No. Please, Rohit, please go ahead.
Oh.
Thank you so much, sir. I think the concept has been proven very clearly that COVID, whether it is due to direct effects on the pancreas and beta cell loss, in addition with the sedentary lifestyle increasing, the two factors have caused increase in obesity and diabetes, and both are of course linked to fatty liver disease. And therefore we are going to see a big wave. Already our fatty liver disease clinic bookings, even though we are doing a lot of telemedicine like Dr. Neelam suggested, are out for 6 months. So we have no space in our clinics. It is a sad situation. So Dr. Yacha, sir.
No, I appreciate Dr. Neelam's overview on this COVID and the liver problem. I have two questions. One is very important regarding this Hepatology International. They have published adults. Why is there a difference between the Italian study, which is in children, versus the adult study, which has been published from here? The question is, have they taken adults any disease control? For comparison, they are showing a huge child A, B, C, whatever, decompensation, whether they have taken a control limb of disease with liver disease who had not COVID and compared them. That would have been excellent. I don't know. I have not read this study in detail. vis-a-vis the Italian study, which is not showing any major problem in the children. And the point which has been highlighted, obesity and COVID, is very well taken. That's very important.
So that child A, child B, no CLD, that was all adults data. And the Italian survey was the pediatric. So what I wanted to say was that we always were very worried that the transplant patients and liver disease, how will they behave? But fortunately, both in Italy and here, but again, I'm highlighting they were all that alpha type of cases that they had at that time. And they suggested the paper which came, the DAY-3 paper, and that survey, that there was no significant increase, only few required hospitalization, and ours is so small. I mean, we had 12 CLD, out of them 1 did require, which is a good percentage. If you see, that means 10%, which is unlike, maybe because we had Delta. And the 2 children who died, which I said were the ones who died in Bangladesh. And they coincidentally had traveled to Calcutta for whatever reasons, family reasons and all, and went. And even Bangladesh, we don't know whether it's Delta or what, but it was shocking that you lose a patient with MISC, because maybe the management, they were all very worried how to deal the fluids and all. With liver, you've got to be extremely cautious in managing these patients. That's all I have to say about fluids and all. But if I say 2 patients dying, it's not a small number. If there were 15 patients and 2 had MISC, though we did not have any MISC deaths in India.
Thank you very much. Thanks a lot.
I wanted to request Rohit to put in a word for Professor Hebe from Cincinnati. Sadly, we lost him, and Rohit had the opportunity to work with him. He's the person who's given a lot in bile acids. So can you please, yes, thank you.
Thank you so much for the opportunity. I know we're all focused on pediatric liver disease, and in one way, shape, or form, we may have come across or met Dr. Hebe over the past 3-4 decades that he was working in bile acid synthetic defects, discovered 8 bile acid synthetic defects, proved their genetic roots with his team, with Ken Setchell and Bill Balistreri together. All 3 of them, I think, were able to define a treatment, cholic acid therapy, and then no small feat for a physician, go through regulatory approval with the FDA here and launch the drug in partnership with industry. So taking truly from bedside, identifying these bile acid synthetic defects, to the bench, defining a therapy, bringing it all the way to market in one lifetime. That is not a small achievement. And on top of that, Dr. Hebe was definitely a humble person, always deferring, always mentoring. And I was lucky enough to be one of his mentees. I can only say that we have lost a great man in our field. So I just wanted to share this sad piece of news.
We pray for his soul to rest in peace. And I would like to thank all of you all and give the podium to Seema as a vote of thanks to the entire chairpersons, and speak over to Seema, please.
Thank you very much, all the speakers and the chairpersons who were here. And my apologies to Dr. Yacha. I did not mean, if this was just...
Sorry, you are my respected colleague. No apologies, please.
Okay, sir. So my apologies to him, and then thanks to everybody. Everybody has been so very involved in this, and it's been a very fruitful session and the wonderful question and answer session. I must say, Rohit, you did come late, but you made up for that. In the chat, I haven't seen a speaker write so much as Rohit has been writing, and I think students were all copying it down, so they will have a lot of good information from you. And also about COVID, I think Rohit has written a lot in the chat box. All you students, please take it from there. Thank you very much, all of you. And now we would take your leave and kind of finish off with this session. Thanks a lot.
to convey apologies from Dr. Anil Dhawan. He's always been a pillar for all our meetings in INSL. Sadly, he had very bad vertigo and he was not able to be stable. And so his apologies, we've all accepted and we wish him good health soon. Thank you, INSL, for the opportunity. Thank you, Seema, for being a lovely host.
Thank you, Neelam.
All of you all, Malathi, John, Yacha, Ujjwal, Asatna, Rohit, Naresh, Anshu, Bikram.
Thank
Cheers.
you very much. Thank you.
Thank you. Thanks, INASL.